Mic check. This is June. June giving a mic check. Hi, I'm June.
Test 1 2, test 1 2 3 4. 1100. Ways and means 1 2 3 4. Mic check. Mic check 1 2 3 4. Ways and means. Feedback.
Oh, yeah, no, I just called the engineer. They're coming up. This mic is on. I don't know if that.
Mic check, 1, 2, 3. Yes.
I see your level here.
Yeah, so if you want to mute the room.
Yeah, the room.
So what that is, why is that muting the room?
All right, while you're doing that, ma'am, what'd you need me to do?
Okay, so that HRS feed, yeah. So if Daryl's down in the booth,
Go ahead. All right, Daryl. Okay, do you need Daryl?
no, I know what the issue is.
Okay. He knows what the issue is.
Mic check 1, 2.
Okay.
Yeah.
All right, then that's,
As soon as I got
thank you. And thank you for putting. You good? Do you need help? He's feeding into the little barbels for us. So you have audio, ma'am? Thank you.
Yep. Turn on TV lights. You gotta do it? It's in there. Broadcast lights.
there.
Yes.
It's the same issue that was happening over the bar.
Hey, Daryl.
Yes.
Daryl. Sure, no problem. No, you can't. Is it not take it out of net? Which one is it? You can?
It's in the
Doug.
Hey, listen, you need to go, take, you told me to take the mic off again.
The audio to 1100 is being routed to 1100. So forgot.
So you know where it's going?
Do me a favor, let me know because we got to put it where you want to be. Thank you, man. Oh, that needs to go down in the closet?
They just have it. So this is going to be a
So what do you need? You got to lift this? Like me, you can watch.
Do they need this?
Wait.
Okay, ready?
Yep. Nah, it's through.
How far
It's through. I'm just gonna plug this in.
you, because I have to.
Now you're good.
Can you pull it?
Now you're plugged in.
You got it?
Yeah. So
Turn it, you just turn the mic on?
all the witnesses are on.
Chris, you got any tape? You have any tape so we can take this cable down?
Finance.
Government reform. Same issue. He got it routed back into his from downstairs. So when government routes, we're gonna have only issue
Size a little more game. Um,
Yeah, once they have the issue, so yeah, and
so this position is live, and I'm speaking into the microphone. And what? Yeah, no, it's the same issue that keeps happening everyone when stuff gets routed.
So up here is good. In the room is good. 1, 2, 3.
Yeah, I'm not hearing you in the booth. That's really weird.
Yeah, I'm not gonna worry about that. I told them if they cut on the TV, then they should be able to get it.
What's that?
If they turn on the perk TV,
Yeah, we'll make do. It's just
yeah. Okay, I'm gonna call Media Center.
I'm not even seeing room level.
You're not?
Yeah.
But I'm hearing it pretty good.
Yeah, I'm just saying, like, I'm looking at the meter here,
Yeah.
and I see 0 room level.
Okay.
On deflection.
Okay. Let me call the Media Center. Okay? Yeah.
Yeah.
I'm gonna call Media Center.
Okay.
Bye.
All right.
Okay. Can you just let me make sure this is set.
Hey, Daryl.
Okay. Can you hear me, Kelly?
I do. Do you know where Doug is? Because I can hear you guys talking. I want to let him know I don't hear it on the analog. I don't know if that makes a difference.
No, that's don't worry about. I mean, can you
Okay,
hear?
I hear you digital, yes.
So we should be good on air.
Yep, I'm going to put you out then.
Okay, make sure the slate is up.
It is. I'm looking at it.
And do me a favor, stick your head around the corner and ask Mo if let me come up, turn the speaker off.
Okay. Well, then maybe we can just maybe scratch it and say, no, we already. That's kind of confusing. Yeah, I would just get rid of that. Okay. Just the idea that we already pay high corporate tax versus this is going to make it even further. And an example of that. Okay. And we have that sheet. Yep. It's so it's in here. So right there is so that's the sheet where he was paying 40% before. And he's now paying nearly 79%.
Mic check. 1, 2, 3, 4, 5. Mic check. 1, 2, 3, 4, 5. You hear nothing on the TV? Okay. You might need to turn that off and on because Kelly does hear you. 1, 2, 3, 4, 5.
Yeah, so with the deductibility, I also have adding a Q&A. You said it is. There are pieces.
Turn that off and on. Yeah, that perk TV gets funny like that.
There's only certain aspects of it that I need to it's a mess. But they're going to try and argue it's deductible. And first off, you have to be profitable to take that deduction to begin with. And you can't deduct all of it. Which is why, otherwise, it wouldn't be collecting revenue. If it was just accidental.
1, 2, 3, 4. Okay, that's what we need. Okay.
That's saying if there wasn't a device tax, he would have been paying 40% with the device tax. Profitable company. Effective tax rate is 70%. Because you're taking that off of sales. Yep. Okay. So then with the rest of the Q&A. Small companies. Many of them are profitable. Again, the 79%. It's
Can we go? Ready to get started? All right. The committee will come to order. We are meeting this morning to consider 10 bills within the committee's jurisdiction. We will consider each bill individually with a separate opening statement and a walkthrough for each. I will begin with my opening statement, and then I will recognize Mr. Levin for any opening comments that he might have, and then proceed to consideration of the bills. So we're marking up 10 bills today, and I'll have more to say on 2 of these bills later. But right now, I'd like to tie them all together and discuss the theme in which they fit. Every one of these bills would fix a different part of Medicare, but all of them would change the very focus of Medicare. That is, they'd put seniors first. They'd make the program more transparent, more accessible, and therefore more accountable. Seniors would know more about how Medicare works, and that would help them find the best possible care. It'd be a big improvement. Right now, Medicare is sort of a black box. The bureaucrats who run the program make all kinds of decisions about seniors' care without much input or any input from the seniors themselves. And some of these decisions are downright baffling. Out of the blue, the powers that be will decide that they'll pay for only a very specific type of a medical device that's basically unusable. And then there are the laws that make no sense at all. Today, we tax medical devices, things like heart valves and pacemakers, the very things that save lives. It's an iron law in economics that when you tax something more, you get less of it. So we've really got our wires crossed here. We want more medical devices. And what we want is less of the bureaucratic meddling that we have these days. That's why one of these bills would also repeal the Independent Payment Advisory Board, a board of 15 unelected bureaucrats that could cut Medicare's payments to doctors and essentially ration care. Every one of these bills would peel back the curtain on the bureaucrats in Washington. We're not asking for much. We're saying things like, tell us how many people enroll in Medicare Advantage. In fact, give people more time to enroll in Medicare Advantage. And while you're at it, give the public more time to review proposed regulations. Explain why you're changing reimbursement rates. Support pilot programs that let plans customize benefits for seniors. Try new methods that put patients first, like other forms of home care. I know Mr. Roscom will have more to say about this particular one later. So you add all these bills up, and the message is really pretty simple. Don't make seniors follow bureaucrats' orders. Make bureaucrats follow seniors' orders. Put seniors in charge of their health care. That will strengthen Medicare for all. I know this is a topic where a lot of us don't see eye to eye on everything, but I'm happy to say that a lot of these bills actually do have broad bipartisan support, because I'd like to think they're just common sense. And I'm glad that we as a committee are working together to help our seniors live happier, healthier lives, and to put them more in charge of their own health care. And with that, I'd like to recognize Mr. Levin for any opening comments he might have.
Thank you, Mr. Chairman. I have an opening statement that will cover the bills where we agree and those where there are differences of opinion. In 2 cases where there isn't the same approach within the Democratic ranks. But let me just say a word, if I might, Mr. Chairman, in response to your comments about bureaucracy. I think all of us are united in thinking that we should try to bear down when bureaucracy is out of hand. I think all of us very much want Washington to respond more effectively. I do think we need to be careful that we not kind of bring out the hatchet when it comes to bureaucracy. Medicare is well run. Medicare is effectively run. The cost of Medicare compared to the cost of private insurance, that cost is very low. So I think we need to be careful that we don't just kind of throw barbs when something is working as when we try to make it work better. So I just think we need to be careful as we work together to make it better, that we not draw a picture as if a government program like Medicare that is working so well to essentially try to put a few horns on it. I don't think the people who receive Medicare coverage today would agree with efforts to essentially give it a black eye. Millions benefit from it. Last week I had the opportunity to visit McLaren Health System in my district, and I was impressed by the innovative work going on to provide quality care, lower costs, and meet high standards. It was a good reminder of how important it is for us to establish federal policies that encourage and reinforce reform efforts. Today, we do so when it comes to the fully bipartisan bills that we are set to consider. For example, the 6 bills related to Medicare Advantage demonstrate that our committee can collaborate in a bipartisan manner, incorporating stakeholder feedback and technical advice to produce thoughtful legislation. These bills contain important member priorities from both sides of the aisle, designed to help Medicare beneficiaries and increase plan transparency. Vern Buchanan and Charlie Rangel and Energy and Commerce member Diane Blackburn introduced legislation to delay CMS authority to terminate Medicare Advantage contracts for plans failing to achieve minimum quality ratings based only upon the STARS rating systems. This delay would provide us with time to weigh the effects of socioeconomic status and complex cases on quality payment program in Medicare, including the STARS rating. The Value-Based Insurance Design Bill, championed by Diane Black and Earl Blumenauer, would establish a demonstration program to incentivize high-value services. There's a bill that would allow CMS to evaluate and consider the risk adjustment methodology to ensure we are appropriately accounting for individuals with multiple chronic illnesses, which Earl Blumenauer and Diane Black worked hard to bring together. And we have a bill to promote transparency and provide critical information on Medicare enrollment for policymakers and researchers, authored by Ron Kind and Mike Kelly, as well as a bill authored by Kevin Brady and Mike Thompson to extend the time period for comment on proposed Medicare Advantage payment changes to conform with the time period for commenting on other major rules. Unfortunately, we are also considering legislation that is not only more controversial, but in my judgment, would undo 2 important components of ACA. Cost containment was an important feature of the ACA, and reform is having an impact. Medicare growth is at a historic low. Congress did set in motion an unprecedented cost containment effort with the ACA and post-ACA and Medicare cost growth is at the lowest point in history. I repeat that, is at the lowest point in history. The Medicare Trust Fund is now extended to 2030, 15 years from now. Medicare beneficiaries are getting improved benefits at lower costs, including free preventive services and closing the Part D donut hole. We certainly had a healthy amount of debate about the Independent Payment Advisory Board on our side of the aisle when the ACA was being drafted. We included a backstop, IPAB, a mechanism to develop further proposals to reduce Medicare spending. Contained it was within reform. The nonpartisan Congressional Budget Office projects that Medicare growth rates will remain beneath the IPAB triggers until at least 2022. The bill would add $7 billion to the deficit over the next 10 years without a plan by the majority to pay for it. Even more consequential is the bill to repeal the medical device tax established in the ACA. Doing so would increase the deficit by $26 billion over the next 10 years. And again, the majority has no plan to replace that revenue. The ACA was fully paid for in part because the industries that would benefit from expanded health coverage agreed to increase revenues from their sectors. The association that represents the medical device community stood with the President in supporting the ACA and communicated with Congress at that time their support for their role in contributing to the ACA. The medical device tax applies to both domestic sales and imports, so there is no competitive disadvantage. A recent Ernst & Young analysis found that the medical device industry's revenue increased by $8 billion in the year the tax took effect. R&D spending has increased by 6% industry-wide, and employment in the medical device industry increased by 23,500. Clearly, this bill reflects the majority's objective to unravel the ACA, and it would let one sector of its commitment to contribute to overall reform, which was predicated on increasing demand for its products. This creates, I think, a dangerous precedent for other sectors, especially with no plan to replace that revenue. I finish on a kind of a happier note, but also not so happy, because someone who has been such an important part of our staff is leaving. Aaron Richardson of the Democratic staff is leaving the committee this month, and all of us on our side, and I think you join in, Mr. Chairman, want to acknowledge her talented work for the committee during her tenure. In addition to ACA, Aaron was the lead staffer on the SGR reforms and the post-acute care reforms. She has real accomplishments to point to, and she should be very proud of the role she has played in health policy and the positive impact her work has had on the lives of millions of Americans who have never met her. I'm confident that she will continue her efforts, but Aaron, we will miss you here in the committee, and I think on behalf of all of us, I might say also you, Mr. Chairman, if I might, we want to thank Aaron for her service to this.
Let me do the same thing on behalf of the majority. Thank you, Aaron, for your hard-fought career, and we wish you the best of success in the future.
Where is she?
Aaron. Yeah, absolutely. Let me do something similar. Before we proceed, we have a new member of our committee. I'd like to introduce Mr. Dold from Illinois, who has joined as our newest member for the committee. So welcome, Mr. Dold, to the committee for joining the Ways and Means Committee. The first order of business is the Protect Medical Innovation Act, H.R. 160. Mr. Paulson, you are now recognized for an opening statement on your bill.
Well, thank you, Mr. Chairman, for bringing up this very important bipartisan legislation. Back in 1990, Congress instituted a new excise tax on automobiles, aircraft, jewelry, and boats. And at that time, the Joint Committee on Taxation estimated the tax would bring in $31 million every year. And instead, the tax brought in only $16 million and led to thousands of jobs lost in jewelry manufacturing, the aircraft industry, and the boating industry. The boating industry went from being a net exporter to a net importer. And once Congress realized that the tax was a job killer and raised little revenue, they quickly moved to repeal it. And in the last 2 decades, human nature hasn't changed. If you apply an excise tax to something, you're going to hurt that industry. So it was baffling that the President's health care law implemented the same type of tax on medical technology and innovation. We aren't talking about regular consumer products. We're talking about life-saving, innovative devices. The medical device industry is really an American success story. It directly employs more than 400,000 people. In Minnesota alone, in the district I represent, there are 35,000 people that are employed in this industry at almost 400 different businesses. Most of these are companies you've never heard of, and that's because 80% of device companies are small businesses with fewer than 50 employees. Most of these companies don't earn a profit for 10 to 15 years. Instead, they're relying on investment and the promise of future earnings to survive. The industry has very good, rewarding jobs, paying an average of $60,000 per year for salary. But most importantly, these companies are producing life-saving and life-improving devices for patients. And only in Washington would you impose a tax on life-saving medical devices and then think you're going to reduce healthcare costs. This tax is on defibrillators, operating room monitors, ultrasound machines, pacemakers, insulin pumps, heart valves, artificial hips, x-ray machines, and ventilators. The list goes on, as well as the new generation of all these devices. And there's several problems with the medical device tax. Number one, it is costing us jobs. A company I connected with recently said they had never laid off an employee in the last 22 years of their business that they've been operating. But they've laid off 22 people, and they've deferred hiring another 15 employees strictly because of the tax. It also is a tax on revenue, not on profit. It's a tax that can decide whether a small business makes money in any given year. One company that has only 20 employees recently told me that they're going to have to borrow more than $100,000 a month just to pay the device tax alone. It's an unmanageable tax increase for a lot of these small businesses. They now have to pay one of the very highest effective tax rates of any industry in the world. Cygnus Medical is also a company from Minnesota. They testified before the Joint Economic Committee just a month ago that they are now paying an effective tax rate because of this device tax of 79%. And who here can justify that? It's harming innovation because instead of investing in the next generation of devices that literally can save people's lives, companies are now reducing investments in research and development, and they're having to hire accountants to deal with a very complicated tax, which they now pay every 2 weeks. And like the previous excise taxes, this tax is already bringing in less revenue than anticipated because it is hurting the industry. The good news is that both Republicans and Democrats recognize that the medical device tax is harming our economy and stifling innovation. It's a very bipartisan bill. 280 co-sponsors in the House, including 40 Democrats. It's also very bipartisanly supported in the Senate because there's recognition that this tax is harming our economy and stifling innovation. I want to thank my colleague, Representative Kind, in particular, for his partnership on this bill, as well as my other colleagues on the committee who have signed on and co-sponsoring the bill. We must repeal this harmful tax and protect American manufacturing. And Mr. Chairman, for the record, I'd like to insert in the record statements and letters from various organizations and patient advocacy groups supporting the legislation.
Without objection.
With that, Mr. Chairman, I yield back.
Thank you. Mr. Levin, you or your designee are recognized for an opening statement on the bill.
I'm going to speak just briefly because I already have, and then I will yield to Mr. Kind. I just want to repeat the results of the recent Ernst & Young analysis. The revenue of the industry increased by $8 billion in the year the tax took effect. R&D spending has increased by 6% industry-wide, and employment in the medical device industry increased by 23,500. The industry participated in putting together the ACA and participated in providing among providers how each of them would put some money into the effectiveness of ACA. And so what this is now suggesting is that the industry which participated now feels that it should be allowed to withdraw in terms of its participation. I think if this were to proceed, we would hear further word from the President. I now yield to the gentleman from Wisconsin, Mr. Kind.
I thank my friend for yielding. Thank you, Mr. Chairman. And I was an original co-sponsor with my friend from Minnesota, Mr. Paulson, on the repeal of this. In fact, I was opposed to this provision being inserted in the 11th hour, airdropped in at the last minute on the Senate side in the course of the ACA negotiations. I thought it was bad policy then. I'm still convinced it's bad policy today. I think this tax on domestic manufacturing does affect the amount of dollars spent in R&D. It's a tax on all revenue, not profits, so even pre-revenue companies, and as my colleague pointed out, many of them startups, those very businesses that we want to be on the cutting edge of new things, new discoveries, new inventions, are disproportionately impacted by all of this. And I too have had an opportunity to visit many companies throughout my state in Wisconsin and heard from them of the disproportionate negative impact that this excise tax has had on their business. And for all those reasons, policy-wise, it still makes sense that we worked very hard to repeal this excise tax on domestic manufacturing and the impact it's having, especially in the R&D area. But having said that, I still believe that for this to get done, we have to find an acceptable bipartisan offset to pay for it. It's a $26 billion cost, and yet this committee has shown a propensity recently this year to bring bill after bill after bill to the House floor with big price tags and no offsets. And if people are wondering why we end up in structural annual budget deficits, this could be another reason if this is brought to the floor with no attempt of an offset. So I'm hoping that between now, this committee markup, and the time for floor action, we have an opportunity to explore some possible bipartisan offsets to come up with the $26 billion that it will take to pay for this. I would encourage my colleagues on the committee to take a look at something that the National Academy, the Institute of Medicine, came out with just a couple of years ago when they did a comprehensive analytical review of all healthcare spending in this country and determined that we're spending close to $750 billion every year in our healthcare system on stuff that doesn't work. It doesn't improve patient care. It's not leading to better outcomes or better quality of care, and it's costing us, obviously, a tremendous amount of money. The Institute of Medicine in that study highlighted the problems with it and came up with recommendations that we ought to be focusing on as a nation to rein in that unnecessary spending and the extraneous expense that currently exists in the healthcare system, and I think we all know it. So I'm not convinced that we can't come together in a bipartisan fashion, find the $26 billion in order to replace that and repeal this bill. I think it's the right thing to do, and hopefully we'll have an opportunity before House floor to continue those conversations. I yield back.
Thank you. Gentleman yields back. The committee will now proceed to consideration of H.R. 160. I offer an amendment in the nature of a substitute, which was distributed in advance, along with a green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and considered base text for the purpose of amendment. I will now turn to Tom Barthold, Chief of Staff to the Joint Committee on Taxation, to provide a description of the bill. I ask that members hold off on their questions until after the presentation. Mr. Barthold, you're recognized.
Thank you, Chairman Ryan, Mr. Levin, members of the committee. You have before you two joint committee documents, JCX 87 and 88, which describe the underlying legislation, H.R. 160, and the chairman's amendment in the nature of a substitute. As noted, the underlying legislation would repeal the 2.3% excise tax on the sales price of covered medical devices, and the chairman's amendment in the nature of the substitute would make this repeal effective for medical device sales in calendar quarters beginning after the date of enactment. Now, what that means is if this legislation were to be enacted in this month, the repeal would be effective for sales July 1st of this year and thereafter. That concludes my description of the legislation. I'm happy to answer any questions that the members might have.
Thank you. Any technical questions for Mr. Barthold? There being no further questions or no questions, are there any amendments to the amendment of the nature of substitute?
Mr. Chairman?
Mr. Neal?
Would it be appropriate to offer a technical statement?
You want to strike the last word after an amendment? How's that sound?
That sounds fine.
All right. I believe Mr. Passerell, did you want to?
No.
You don't want to offer
I
an
want to
amendment?
strike the last words.
So let me just dispose of amendments. Are there any amendments being offered? If not, then why don't we move to members?
Chairman, Mr.
Yes.
Chairman, I was going to enter my amendment and
Okay.
then withdraw it, but I ask your support on
Gotcha.
something.
Well, the
May I
gentleman's
do that?
recognized.
May I do that?
Gentleman's recognized. The clerk will distribute the amendment, and I ask that the gentleman give us a second to see what it is and let them distribute it first.
Mr. Chairman,
Gentleman from Texas.
on this, I reserve a point of order.
A point of order has been reserved. Let's see. No. This is not an order. Ready? You ready? I just want to make sure everybody gets the amendment. All right, the gentleman from New Jersey is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, in September of 2013, the Food and Drug Administration published its final rule requiring that most medical devices distributed in the United States carry a unique device identifier called a UDI. The UDI implementation started last year and will be complete by 2020. The UDI is a system that assigns distinctive codes to medical devices so they can be adequately identified through their distribution and use. The UDI is an extremely important patient safety tool and can help identify safety concerns with devices more quickly or disprove a suspected problem, as is the case with any new medical technology. Not all adverse events are detected in the product's market approval or in the clearance process. However, we can mitigate the impact on patients with a robust post-market surveillance program. So in 2013 and 2014 alone, the FDA recalled more than 120 medical devices. In many cases, the recall occurs only after the devices have been implanted in or used by hundreds of thousands of patients. This can result in extensive revision surgeries, severe pain, other medical problems. And Mr. Chairman, I might add, my own friends had gone through this situation. I've been working on it since 2007. I bring it to your attention. In 2001 device recall case, Sweden's post-market surveillance program successfully identified the faulty device after it had been implanted in 30 patients already. By contrast, the same device was implanted into 3,000 United States patients before the gravity of the problem was recognized. The FDA's Sentinel initiative, which has been very successful in tracking and evaluating adverse events linked to the use of pharmaceuticals, relies primarily on data from health insurance claims. So note, because claims currently lack information on the specific devices used in a patient's care, Sentinel cannot be expanded to include medical devices, as Congress has directed FDA to do. This is a missed opportunity. This amendment would direct the Department of Health and Human Services to take steps to ensure that the UDI appears on Medicare claims, which would allow adequate monitoring of the safety of these medical devices. As we've heard today, all of us here have strong feelings about the medical device tax, and I'll speak to that a little later. But my amendment sets all of that aside. This amendment is about improving patient safety, plain and simple. Patients deserve access to innovative new devices, Mr. Chairman, and I'll vote for this amendment, even though I'm going to be withdrawing it since you say it's not germane. I know that my amendment may not be germane, but I ask you to please join with me in getting to the bottom of this and helping patients throughout the United States. With that, I yield.
I thank the gentleman for his statement. As the gentleman knows, it's not germane in this context, so does the gentleman withdraw his amendment? Okay.
Mr. Chairman, I'd like to speak before you do that.
Okay,
If
gentleman
I
move to
may-
strike the last word.
I may, Mr. Chairman, like to
Gentleman-
withdraw the reservation of the point of order.
Okay. Does the gentleman move to strike the last word?
Yes.
Gentleman's
I
recognized.
move to strike the last word. This is not the first time this issue's been brought before the committee. And the committee leadership has suggested that there would be a consideration of this issue. But it doesn't happen. Now, what Mr. Pasquale is talking about, let me put a fine point on it. If a woman has cancer and they remove her breast and they put a replacement in her chest and suture it in, and then some problem develops with it, it begins to leak, there is no identifier on that breast replacement. Now, if you don't want to protect people, and you don't want to know which is the bad provider of technical devices, medical devices we're talking about, then you will continue to leave them unmarked. Because lawyers can't go to court and say, well, there's a problem in my patient here, but I don't know where it came from because it's not marked. And the hospital has nothing to put in the record that they put in device H17B5 from this company or that company, so there's no record in the hospital as to where it came from. So then it's a question of, well, did it come from the storeroom? Well, there were 4 or 5 different devices back there. We don't know which blocks we used in this patient. And what you're doing here is taking away a protection from Americans. Now, this is just not breast replacements, it's stents. You have a blockage of an artery, they stick a stent in there. If there's no identifier on it and it doesn't work, it has to be replaced or whatever, there is no recourse for the patient because they don't know where it came from. That's what Mr. Pasquale is trying to do. We've offered this amendment twice before. We've withdrawn it, as we are again today. But I want to make it clear that the Republicans do not care about protecting patients. They are protecting companies who produce these devices. And it's a choice. And I fall on the side of Mr. Pasquale. I understand the germaneness. I've been around this game long enough to know you can always figure out how to make it ungermane. But the fact is that this is an issue that this committee ought to deal with. I yield back.
Gentleman yields back. We're off to a good start today. I'd now like to, the gentleman from Texas, Chairman of the Health Subcommittee, do you wish to strike the last word?
I would like to strike the last
Gentleman
word.
is recognized.
Just briefly, I think Mr. Pasquale has a good idea. I think this is an important issue going forward. We'd like to continue to work with you to get it in the right shape. The good news is as Chairman Ryan has made clear, we're going to move good health care policy in a bipartisan way. We think this fits exactly where the committee ought to be going. Just continue to work with us to just get this in a place where we can move it, Mr. Pasquale. Chairman, I yield back.
Gentleman yields back balance at his time. Does the gentleman withdraw his amendment?
I withdraw the amendment.
Gentleman withdraws the amendment, and I'll just simply say that this is not the only markup we're going to have this year. Does anyone else?
Mr. Chairman.
No other amendments? Okay, does the gentleman move to strike the last word?
Move to strike the last
Gentleman's
word.
recognized.
Mr. Chairman, I think an institutional memory is appropriate here, and to remind people of how we arrived at 2.3%. If you recall, the Democratic leadership was at 5%. This is a very important industry. The arguments that have been made are very salient, but not to miss the point that we ratcheted back the proposal from 5 to 2.3%. And it seems to me that one of the frequent arguments that occurs in this committee today is arguing about the past, as opposed to discussing the future. So when we offer an amendment today, simply saying it's feel good enough to allow us to subtract the money from the ACA, but not replace it, and then to suggest that we can keep the ACA in its current position. So Mr. Kine suggested that we need a bipartisan solution to replacing the pay-for the medical device tax. Nobody's arguing against innovation. We're pointing out that this was put in place for a very important consideration. Medical inflation as it relates to the ACA has all been positive. Costs are being ratcheted back, and there's an opportunity to demonstrate some bipartisanship here rather than this constant argument that appears in like the twilight zone. How to make this better going forward. So in deference to the gentleman's proposal here to get rid of the device tax, why don't we offer a pay-for that stands up under the critical analysis of the magnifying glass, where it can be scored by CBO and joint tax as being consistent with the thrust of the ACA, and that is getting medical care to an underserved part of the American population. And I have said repeatedly to those who have visited with me, if you come up with an appropriate pay-for, I'm in. Now, I also want to point out that when we move to IPAB, I'm going to offer the same institutional perspective. For those who march around this Congress with the Constitution in their pocket, we're going to have, I hope, a full-throttle discussion about the constitutional relevance of IPAB.
Mr. Johnson, do you move to strike the last word?
I do.
Gentleman's recognized.
Thank you, Mr. Chairman. Mr. Chairman, I'd just first like to salute my colleague from Minnesota, Eric Paulson, for his leadership. And Mr. Chairman, thank you for bringing up this important bill to repeal the Obamacare medical device tax. Colleagues, make no mistake about it. This Obama tax penalizes innovation, life-saving innovation at that, as well as it hurts jobs. For those who may not know, it's affecting one of my own companies back in Plano, Great Batch. For those of you who don't know it, it's a company founded by Wilson Greatbatch, who co-invented the first implanted pacemaker. Now, here's what Greatbatch tells me. This Obamacare tax, when combined with other taxes, is like a death by 1,000 cuts. Due to the medical device tax, Greatbatch has to defer various R&D projects as well as hiring decisions. For a company like Greatbatch, it spends millions and a good several years to bring new devices to market. But you know what? Thanks to this tax, Greatbatch is taxed by Uncle Sam on its very first dollar of a sale, even before it makes a dollar back on its investment. Bottom line, it's a terrible punishing tax, needs to go, needs to be repealed. Mr. Chairman, I'd like to submit for the record a letter from the National Association of Manufacturers. In the letter, NAM states, quote, as a result of the tax, the industry has lost over 17,000 existing jobs and over 20,000 potential new jobs. Mr. Chairman, thank you again for bringing the bill up today.
Without objection, it'll be included in the record.
Mr. Chairman.
Mr. Pasquarello, then we'll do Mr. Pasquarello, you move to strike the last word?
Yes.
Gentleman's recognized.
Thank you, Mr. Chairman. Mr. Chairman, I've seen, the first part of what I have to say here is about I've seen and been with folks through the pain of having reoperations to replace prosthetics. And as was pointed out by a gentleman from Washington State, when you have to do this, now, I know this industry, and what I have to say now is for the record, Mr. Chairman, I strongly oppose repealing the medical device excise tax. First of all, this industry was at the table when negotiations went on. When the Affordable Care Act was being negotiated, they agreed to help pay for the law. But because of the ACA, the health care market includes millions of newly insured Americans, which drives up the demand for the medical devices and other health services. We're missing the whole point here. How many people have been brought into the fold, been able to get what they should have had before, and increase the businesses? The device industry wants it both ways. They want the new business the ACA has created for them, and since the law was passed, they've been lobbying to appeal it. Talk about 1,000 cuts. You're trying to do 1,000 cuts to the ACA. I support the ACA and its goals, and I said that in 2010. I'm not afraid to say it now. But it's got to be funded somehow, some way. And we can debate that. That's healthy. You can't support the goals of the ACA, then start stripping out the pieces of the law that fund the realization of the goals. This legislation would add $26 billion to the deficit. I remain very concerned about some of the behavior we have seen from this industry over the years. I became highly involved in the medical device issues in 2007 when a number of device manufacturers entered into controversial deferred prosecution agreements for providing doctors with bribes and kickbacks for using knee and hip replacement devices. That's on the record. And if you don't know what a deferred prosecution is, I'll tell you afterwards. Because it's been used by both Democratic and Republican administrations. And it's a phony way to do business in America. A number of these products ended up being recalled because they were unsafe. That's the record. You can't make up this stuff. It's the record or it isn't the record. And the companies escaped the system without even a slap on a wrist. The cost of doing business was a fine. As a result, Mr. Chairman, on the justice side, I worked to put an end to deferred prosecution agreements that don't hold bad actors accountable. No, it's not the total industry. There are great companies that do this work, and there are some companies that have escaped the prosecution of the law. I've also worked to improve the safety of medical devices for patients by encouraging the use of clinical data registries. Maybe some of you remember that. A provision we added to the Medicare Program Integrity Bill this committee considered earlier this year would help provide the guidance on the applicability of privacy laws to help bolster participation in registries. So I don't think, Mr. Chairman, that repealing this tax is good policy. It's not good for the budget. I urge you to rethink this and to look at the data which has been presented here, which, as the ranking member pointed out, Mr. Levin, is suspect, to say the least. I ask you to look at it, that we come up with something together. I like that idea. I trust Mr. Brady's comments, what he said before. But I think we need to take a look at this industry, and we need to take a look at the safety of patients, Mr. Chairman. Thank you.
Time for the gentleman has expired. Mr. Bustani, do you seek to strike the last word?
Yes, I do.
The gentleman is recognized.
Last word. I feel compelled to speak on this. In the course of my career as a cardiac surgeon doing open heart surgery, I had the great privilege of using a lot of these devices, oftentimes from very first generation to the most modern many times over. And there's several elements missing in this debate. I remember putting in defibrillator, the very first implantable defibrillator. It was this thick, it was that big, it was a major abdominal operation. Now cardiologists put these in through a little subcutaneous incision with local anesthesia. It's quite amazing. The innovation has been astounding. And what's missing, we talk about the cost of this, but what's missing is the tremendous humanitarian benefit from this technology, number one. And secondly, there is a reduction in cost. The hospital stay from these first-generation defibrillators was almost a week. Now it's not even a day. They go home. There's a significant advantage in cost that's not being calculated in the way we capture cost. Secondly, heart valves. I remember hospital stays could last 3 and 4 weeks, 7 or 8 days in the intensive care unit after heart valve operation. In the last days of my practice, we were sending them home in 4 days. That's a significant cost saving, significant reduction in complication rates and so forth. I can go on and on and on. I mean, the time's limited here, but the fact is, we are missing the sight of the advantage, the tremendous, amazing innovation that's occurred in this country. So why do we want to tax it in a way that stifles innovation, hurts patient care, and runs up cost? I mean, I can talk about what's happened with ACA. I mean, we have loads of patients now by many different assessments running to the emergency rooms and getting less than good care because they're getting it late. late in the disease process, and it's, you know, it's expensive. It's not good for the patient. Why do we want to tax innovation? Why do we want to tax the most innovative industry we have seen in a century?
Well,
I just
gentlemen,
don't get it. I'll yield.
Thank you. Thank you, Doctor. I have a great respect for you. I'm not a surgeon, but you know as well as I do that from 2000 to 2010, there were many cases before the courts and the federal courts. You can't deny that. You didn't do that. I didn't do that. The facts are the facts.
Well,
all I'm saying,
I'll reclaim my time, but I'll just say that no device is perfect. But the beauty of innovation is we get better and better with better patient outcomes and lower cost and higher quality. So there's not only an economic advantage to this, there's a humanitarian advantage to it. And so with that, Mr. Chairman, I wholeheartedly support Mr. Paulson's bill. I think he's done a wonderful job in advocating for this over time. Passage of this bill is long past due. It's time. Let's pass it and let's move on. And I yield back.
Gentleman yields back. Gentleman from California, do you wish to strike the last word?
Thank you, Mr.
Gentleman's
Chairman.
recognized.
I do wish to strike the last word. This debate's been very, very interesting, and what's been said on both sides can be pointed to as factual. The innovation is fantastic. These companies are doing great work. But I want to return to the point that my colleague from Massachusetts made, and that is this bill puts a big hole in the Affordable Care Act. It spends $24.4 billion that we don't backfill. It's not paid for. And I think we need to have the debate as to whether or not we should tax medical devices, but we need to have it in context of fiscal responsibility. And this bill isn't fiscally responsible. And I'd just like to enter into the record, Mr. Chairman, a list of the tax provisions that we've passed, that this committee has passed this year to date that have been unpaid for.
Without objection.
$556.3 billion. Add to it this bill, and it's $610.7 billion unpaid for. I'd like to enter this into the record.
Without objection.
Thank you. I yield back.
Gentleman yields back. Dr. Price, did you?
Move to strike the last word, Mr. Chairman.
Gentleman's recognized.
Thank you, Mr. Chairman. I think that it's incredibly important that we think about what's going on here in the way of innovation and how it's affecting patients, how it's affecting real people. We are harming innovation. As a physician, I spent over 20 years taking care of patients. As an orthopedic surgeon, I've put in thousands, if not tens of thousands, of implants into patients. The fact of the matter is that right now, in this country, physicians who are on the cutting edge, surgeons who are on the cutting edge, are no longer able to go to technical meetings in the United States and find out what's on the cutting edge. Because what's on the cutting edge in the world is elsewhere. Because we in this country are destroying the innovative capacity of companies in this nation. And there are a lot of reasons for that, but one of them is the medical device tax, a tax on gross receipts, something we've never done before. I also think it's important to make certain that people who are watching and will be reading this and listening to this debate, physicians in this country, healthcare workers in this country bend over backwards, do all that they can to make certain that patients are safe. And this goes from A to Z, but when we're operating on an individual and we're putting an implant in an individual, I did thousands of total hips, total knees, fracture fixations, and fixing with plates and all sorts of implants. And every single time, in that patient's chart was entered where that implant came from, the company that it came from, the number of the implant, so that if there was any problem at any point in time, we knew exactly where to go to determine whether or not there was a flaw in the development of that device. So it's important that people appreciate that the work that's being done out there by the healthcare professionals in this country is second to none in trying to make certain that patients are safe. And when we would operate on an individual, in that patient's chart, was the sticky piece of paper that went in that patient's chart that identified exactly what we put into that individual. So I know the gentleman's amendment is well-intentioned, and I know this discussion is well-intentioned, but I'm here to tell you that we are losing innovative capacity in this country, and to imply that there are things going on that are not keeping patient safety paramount is just inaccurate and doesn't do a good service to the debate that we need to have. So I urge adoption of the underlying bill and yield back.
Gentleman yields back balance of his time. Mr. Becerra, do you move to strike the last word?
I do, Mr. Chairman.
Gentleman's recognized.
Thank you very much, Mr. Chairman. First, let me applaud the gentleman for the legislation. I think all of us recognize that, and California has a lot of the industry that develops a lot of these innovative devices, and so I think we all want to make sure that these industries have an opportunity to move forward. And I think just about every member on this committee would say, let's go forward and let's undo the tax if, as some of my colleagues on this side have said, we come up with a pay-for to make up for that revenue. Because you don't come up with the revenue, and what you're telling a lot of Americans is that we're going to have to cut back on what they can expect to have in their health insurance plans through the Affordable Care Act. Or you're going to tell another industry, guess what? We're going to have to decrease your reimbursement, whether it's a doctor like Dr. Bustani, or whether it's a hospital like any hospital in our district. We're going to have to tell those providers, we're going to have to cut back on how much we reimburse you through this program because we have $24.5 billion less to provide those services. And so it's not that there's an industry that deserved to have a tax imposed on it, that was a bad actor, and therefore we wanted to punish. No, these medical device companies do phenomenal things for Americans who today are alive as a result of all that innovation. And as someone who comes from the state of California, probably the most innovative state in the nation, we want to continue that. But here's the problem. As who was it that said it? I don't know if it was Mr. Pasquarello or somebody said it earlier. You got to face the fact that these things cost money. If you're going to provide services, it's not free. Money doesn't grow on trees. And any American knows that. You got to pay for the services for your kids, for your parents, when they get health services. So I think what we're saying here is compare to what? So the medical device tax, which the medical device industry understood when we passed the Affordable Care Act was going to go into place, and they understood because they'd get a lot of new business as a result of all those new millions of Americans who would get insurance coverage and now could use those medical devices, that they understood they were going to give at the office. So here's some numbers. This bill, the tax itself for the next 10 years will collect about $24.5 billion from the medical device industry. So it's about $2.5 billion a year that's collected in taxes from the medical device industry. In the first year that the medical device tax was collected, the industry grew its profits by $8 billion. So as a result of the Affordable Care Act, this industry is doing much more business to the point where it raised $8 billion more in profits than it had the previous year. And so, is it painful? Yeah, it can be painful. But is it paying for itself by having new service and new clients and new patients who use the medical devices? Absolutely, that's proven itself. But the more important point is, if you're going to give it back to Peter, what are you doing to Paul? And here we have to be honest with ourselves. We got to pay for things. You can't just continue to say, I want to do you a favor, I'm going to be good to you, and we're not going to pay for it unless we want to continue borrowing from China to pay for all these things. At some point, you got to pay. And that's what we did. We made sure that this new Affordable Care Program that gave millions of Americans, for the first time, access to good insurance coverage, or for those who had lost it, access again to good insurance coverage, was covered. So it wouldn't be done on the credit card of the federal government, or it wouldn't be done in future taxes to our children. And so if there's a good pay-for this, I think Mr. Paulson would find that there will be a lot of votes on this side of the aisle. But we have to come up with a way to pay for it. It's painful. I'd love to be able to say, as a member from California, we're going to undo this. And I'm prepared to say that if we come up with a different way to pay for the good services that millions of Americans are now receiving through their health insurance. So with that, I want to again compliment those who want to try to find solutions, but let's also find the pay for it. So with that, I yield back to
Gentleman yields back the balance of his time. Mr. T-Berry, do you move to strike the last word?
Move to strike the last word.
Gentleman's recognized.
Boy, I hope my constituents are watching this. This is fascinating. I'm not even going to talk about the fabulous innovation that we've already heard about. I'm going to talk about this issue of pay-fors and this issue of $24 billion. I want my constituents to know about a bill, H.R. 2050. 2050 is a bill to repeal a tax of the ACA. It must be an attempt to try to undo the ACA, piece by piece. $80 billion, H.R. 2050. That's what it cost, $80 billion. Must be a horrible piece of legislation, not paid for. Its authors must be attempting to really strike a heart through Obamacare. But then I look at that, and I think it's trying to help police officers. I think it's trying to help firefighters and teachers. I look and I see my friend Bill Pascrell as a co-sponsor of the bill. And I know you're not trying to undo the ACA, even though it cost $80 billion, not paid for. There's 83 Democrats. The lead sponsor is a Democrat. No one's questioning Mr. Courtney's whatever you want to call it, his Americanism, his patriotism, his integrity, or his belief that this is bad policy that needs to be gone.
Would the gentleman yield?
I'm not finished, but I'll yield. I'll yield.
Thank you. Thank you, Mr. T-Berry. Mr. T-Berry, CBO scored the taxes that were included in the ACA as adequate pay-fors.
Right.
That's the dispute we're having now.
Right.
That's about the dispute. We're saying if you take this away,
right,
then you can't pay for it.
Well, my point, reclaiming my time, is that H.R. 2050 is not paid for. There's no pay for it in repealing the Cadillac tax. Now, I'm not going to make any sort of assumptions that there are 83 sponsors because the AFL-CIO is for the bill and the Federation of Teachers is for the bill and the laborers are for the bill or whoever else is for the bill and its policy. I'm not making that assumption. I'm just saying that I just find this a striking debate that there is a bill that repeals a significant part of the Affordable Care Act that's not paid for with 83 Democrat co-sponsors, a Democrat-led bill, including Democrats on this committee, and no one on this side of the aisle is saying, well, the intention of the sponsors is to strike the heart out of the ACA.
Would the gentleman
because, no, I'm not going to yield any more because I've only got 5 minutes. So my point is this.
And I'll take 5
There
minutes.
are a lot of people who have a lot of angst about provisions of the ACA, both on your side of the aisle, quite frankly, you know this, and our side of the aisle. Our point is, and compared to the H.R. 2050, which is approximately an $80 billion cost, that's not paid for in the legislation that the lead Democrat introduced. No one is questioning his motivation. No one is questioning his sincerity, his integrity. We shouldn't be questioning anybody's sincerity who wants to repeal an important provision about American innovation. That was my entire point. My entire point is let's not impugn the integrity of people who have an honest disagreement on how to proceed with respect to the cost of an issue. No one has with respect to H.R. 2050 on this side of the aisle. We shouldn't on that side of the aisle either. I yield back.
Gentleman yields back. Mr. Larson, do you seek
to strike the last word?
Gentleman's recognized.
Chairman, thank you for this hearing. Let me also echo a number of the sentiments that have been expressed, most notably about Mr. Paulson and Mr. Kine. The two Midwesterners do exceptionally good work, and I think they've provided a good piece of legislation, although, as Mr. Kine points out, it has a huge gap in it. Let me also refer to something that Mr. Neal brought up with respect to institutional memory. I would point out in this chamber that the twice passed bills with respect to the Affordable Care Act neither contained the Cadillac tax that Mr. T-Berry just alluded to, or did they contain a medical device tax? And so I think, Mr. Chairman, what we need to do here, as Mr. Neal, Mr. Becerra, and others have suggested, we really need to focus on the pay-for-its. Nobody is against innovation, and I commend those people who have spoken about this industry. And far from criticizing them for being at the table and saying they were willing to step up to the plate, they should be commended. Many other people were at the table and then walked away. In fact, there was a point in time when even Mr. Grassley was at the table and offering positive ideas about how we could move this forward, and then people walked away. I can't fault an industry that sees everybody else walking away and feels it unfairly is paying a burden, and especially in lieu of all the innovation, science, and technology that has been articulated so well here. However, the notion somehow that the public doesn't perceive that a body then governing became a minority party because of this issue, because the party now governing said they would repeal the Affordable Care Act. They would repeal it in its entirety. They haven't been able to do that. And so the perception is that this is death by 1,000 slashes. Notwithstanding, I don't indicate that anyone on this committee, and most notably the sponsors of this bill, are proposing this specifically with that in mind, and certainly not Mr. Kind, but it does raise the issue. We could, I guess, say in this committee, everybody who wants to repeal the Affordable Care Act, raise your hand, but that would be childish. What I do believe we need to do is to look at these pay-fors. Now, it was also true back in 2009 and 2010 that Reuters and other people said that there are $700 to $800 billion annually in waste and inefficiencies that exist in our healthcare system. Why aren't we doing, as a committee, what we did last year with respect to taxes? Let's break down and sit together. Let's come up with, we know that those numbers combined, the total Affordable Care Act over a 10-year period is $950 billion. There's $700 to $800 billion annually in waste and inefficiencies. That's where we should be sitting down and working together to come with a goal. Rather than wringing our hands about this issue, let's step up to the plate and recognize that, yes, that was an imperfect bill. Yes, we need to make the corrections, but let's do it in the best interest of the American people and not continue this taste great, less filling argument. I want to see this tax lifted off of the medical tax device providers, but I don't want to do so at the expense of leaving these gaps in a system that people are saying, so this is how the repeal of the Affordable Care Act is going to go down. Thank you, Mr. Chairman.
Gentleman yields back. Mr. Young, do you seek time?
I do, Mr. Chairman.
Gentleman is recognized.
I thank Mr. Paulman, firstly, for his leadership on this issue, and I thank the chairman for bringing this bill before the committee. The medical device tax has already, of course, been devastating to innovation, patient care, job creation, especially in my home state of Indiana. Thousands of jobs have been eliminated. Companies are making the difficult decision to move their product lines and jobs overseas. R&D has also been significantly reduced and capital investments have been cut back. Now, some have said that this tax hasn't had an impact on the industry because the cost would be passed on to the consumer, as if somehow this is a good thing. But the facts dispute this contention. Mr. Chairman, I want to enter into the record a number of letters where suppliers and hospital systems have been clear they wouldn't accept a rise in consumer costs.
Without objection.
The fact is that the costs of this tax are being borne by medical device providers. And with that in mind, some say it's okay because these are big companies that can absorb this tax. However, this ignores the reality that more than 80% of the nation's roughly 6,500 medical device companies have less than 50 employees. These are small businesses. And one thing we know about small businesses is that small businesses operate on small margins. It's the small companies who develop disruptive technologies that change medical care. But investment dollars in new medical technologies is drying up because these companies are being taxed on their gross sales, not their profits, and therefore they have to send the very first dollar they earn to Washington, D.C., even though, in many cases, they're many years from paying off their investors and earning a real profit. So regardless of what opponents of device tax relief might say, the costs of this tax are being felt by many small businesses, and that's leading to reduced investment here in the United States. We know this tax is having a negative effect on these businesses and is hurting their efforts to invest resources and create American jobs. In my own district in Indiana, we have a major medical device company that has said, without repeal, they will move a large new device-related product line outside of the United States. Now, their previous plans were to open up 5 new device manufacturing facilities in American towns. But the capital that was set aside for this expansion was instead used to pay this device tax. This Hoosier company isn't the only one, of course. We've read reports of job cuts on account of the device tax and other medical device manufacturers that have curbed U.S. expansion due to the tax's costs. Every day this tax remains in effect, we continue to slow medical advancements, hinder patient care, job creation, and innovation. Today's and tomorrow's patients depend on these cutting-edge, life-saving technologies in order to live longer, healthier lives. So I urge all of my colleagues, Republican and Democrat, finally to repeal this harmful tax. I yield back.
Gentleman yields back. Mr. Levin, did you want to strike the last word?
Yeah, just briefly.
Gentleman's recognized.
Am I the last person on the list?
Okay. No, you're not.
I'll be very brief. You know, I do think it's important to look at studies, and again, I want to refer to the Ernst & Young study of 2013. And it said that the revenue of the industry increased by $8 billion the year the tax took effect, that R&D spending has increased by 6% industry-wide, and employment in the medical device industry increased by 23,500. So I think we need to take a look at all of the facts, as well as perhaps some information that comes from a particular place. But let me just say something to Mr. Teaberry, if he's here. He's not here. But I'll say it anyway. You know, it's one thing to introduce a bill and in the introduction not indicate how it will be paid for. It's something else to bring it up before the committee, any committee, and pass it without paying for it. It's very, very different. And then to indicate that it may not have to be paid for when it comes to the floor. This committee has been doing that with numerous bills, resulting in last year, was it $600–700 billion in terms of bills that weren't paid for. So nobody is challenging the integrity of anybody else, but we are challenging the obvious effort of the Republicans to essentially, piece by piece, if they can't do it entirely, to repeal ACA. And the record is very clear about that. And so it's not a question of integrity. Part, I think, of the motivation of bills relating to ACA that aren't paid for, part of that result, if not the motivation, is essentially to begin to tear apart ACA. That has been the primary objective of the Republican majority.
Will the gentleman yield?
Yes.
So is it the primary goal of Mr. Courtney to tear apart ACA?
No, but his bill...
So who gets to decide?
Let me just... The committee should decide.
No, you just said the primary motivation is to tear for
I know,
Republicans.
no,
so if
because
I'm on Mr. Courtney's bill, my primary motivation is not to tear apart
No, but let me just finish.
If I'm on Mr. Paulson's bill, my primary motivation is to tear apart ACA.
No.
That's my point, Mr. Levin.
All I'm saying, let me take back my time.
Gentleman controls his own time.
Look, Mr. Courtney introduced his bill without a pay-for, but it hasn't been acted on a committee, and brought out a committee without being paid for. That's very different. That's very different. And it's even more different when the intention may be to pay, to proceed with this bill without a pay-for. So I'll ask the majority, do you intend to provide, if you bring this on the floor, to pay for it? Is there going to be a pay-for? Will you commit now to providing a pay-for this bill when it comes to the floor? I think the answer is probably no. So it reflects on the purpose of the legislation, because other legislation has brought forth to try to undo ACA without paying for it. So that's my point. I yield back.
Gentleman yields back. Mr. Kelly, do you move to strike the last word?
I do.
Gentleman's recognized.
First of all, Mr. Chairman, thank you. Mr. Paulson, Mr. Kine, thank you for bringing this forward. And I know we get in these difficult conversations because it becomes, well, are you really want to take care of people, or do you want to take care of big businesses? And I would say that they're both the same thing. This bill to pull back this excise tax, and I think you have to understand, and when you're in that industry, anything that's added to the total cost of what it is that you produce becomes part of that cost. And my assumption is that these companies that we're talking about are having such great sales, they're also having profits, and they're paying a percentage of their profits every year in taxes. Everybody that works at these companies is paying wage taxes, they're paying income taxes, they're going out and buying homes and cars and whatever else, and they're paying sales taxes. And so when we start talking about dismantling thing, I really would believe that it should have been constructed right the first time, from the ground up, with a really strong foundation where there was money there to do it. I know it was well intended. It just doesn't make sense when you say, well, these people are going to have to pay for it. They're making billions of dollars in revenue. And my friends, I would suggest to you, unless you've done it, sales and profits are two different things altogether. There's companies that have great sales years and go out of business because they didn't make a profit. We are talking now about the health of our economy. We're talking about the health of these companies. We are saying to them, continue to innovate, continue to create, continue to do things that save people's lives. And by the way, if you stay here, we're going to keep on taxing you till we make it so uncomfortable that you have to go offshore. And once you go offshore, we're going to accuse you of being unpatriotic and not wanting to pay your fair share. Does anybody get this? And I would just suggest only in this town, where we take every single person out there that makes a profit or is paying a wage, and we drain them of their income and say, you must do this if you're a true American and you really want to take care of people. This is not about Republicans not liking people and Democrats liking people. The last time I looked, we're all people. I like all of you guys. I just don't get it, how you think when it comes to this stuff. I guarantee you, you raise the cost of doing business on these people, and you know what they'll do? They'll go someplace else where it's a little more friendly to be there. This is not hard to figure out. And yet we talk about this. And I will tell you this. There's an old saying where I come from. It's about don't worry about the mule, just load the wagon. Most of the mules are unhooking themselves right now and walking away. They're going to a place where the pastures are a little bit greener and the people that rely on them for doing the job are a little bit nicer to them. We cannot continue to grow our economy. We cannot continue to grow our revenues when we put a heavy burden on those that produce that. It's just that simple. This is not about not wanting to take care of people. This is about, yes, we want to take care of people, but you know what? I want to make sure they can stay in business so they can continue to be in our towns, support all our different charities, support our tax base. That's what it comes down to. How did we get to this point where it's about people who have a heart, about people who don't have a heart? It just doesn't make sense. So Mr. Paulson and Mr. Kine, thank you so much. I wish there had been more thought about how we were going to pay for this when we actually put the thing together to start with. as opposed to saying, hey, you know what? Here's an industry that's not paying an excise tax. Let's go after them. Let's make it harder for them to be profitable. Let's make it harder for them to innovate. Let's make it harder for them to create, and then let's blame them for not wanting to participate. That is absolute insanity. Mr. Chairman, thank you for bringing it up. I yield back.
Gentleman yields back. Ms. Noem, do you seek to strike the last word?
I do, Mr. Chairman.
Gentlelady is recognized.
Mr. Chairman, I ask unanimous consent to enter 2 documents into the record.
Without objection.
The first is my opening statement on the bill. The second is a letter from the U.S. Chamber of Commerce addressed to my colleagues, Congressman Paulson and Congressman Kind. And in its letter, the Chamber points out that the medical device tax has already had real and destructive implications for our country's economy. It reiterates that companies have already reduced R&D due to the tax, which has been stated previously here today. Others have deferred or canceled capital investments or canceled planned expansions. I'm a proud co-sponsor of this bill, and like the Chamber of Commerce, I'm worried about the damage this tax will continue to inflict on small businesses around the country. So I just urge my colleagues to vote for this bill, and with that, I'll yield back the balance of my time.
Gentlewoman yields back balance of time. Mr. Crowley, do you move to strike the last word?
Yes, I do, Mr.
Gentleman's
Chairman.
recognized.
I yield to the gentleman from New Jersey, Mr. Pasquale.
Mr. Chairman? Mr. Chairman, I just want to correct one of the many impressions that are incorrect that have been just thrown out here. This tax applies to imported devices and prosthetics as well, so that the Americans' companies could not be placed in a disadvantage, Mr. Chairman. Read the bill. Read the legislation. We're not against innovation. We support it. And by the way, you know how many times you guys and gals on the other side have voted against our attempts to make that incentive for innovation in the last 3 or 4 years? Very embarrassing. Don't say that we're against innovation. I'm not. Many of these companies are great American companies. But you don't know the history of some of these companies, the larger companies. I do. And I am compelled morally to share it with you. And that's the only thing I've got to say, and I yield back.
Will the gentleman yield?
Absolutely.
You know what? Morality just doesn't exist in New Jersey. We actually have the same feelings in Pennsylvania, the same hearts and the same concerns.
Good.
I'm talking about making sure that we give our own companies the advantage to win, because they're going to pay taxes on this.
Now you know. Now you know.
Reclaiming your time.
Now you know why I brought the subject up, because imports are taxed just like American products are taxed. You understand what I'm saying?
Oh, I do.
Thank you. No, nothing more to say.
Gentleman yields back. Mr. Meehan, do you wish to strike the last word?
Yes, I do, Mr.
Gentleman's
Chairman.
recognized.
Just very briefly, I want to thank my friend, the gentleman from Minnesota, for his continuing persistence and leadership on this. And, you know, we're trying to turn this into a moral issue. I have had the opportunity to actually prosecute the big companies that have handled and abused the privileges in our healthcare systems. But the fact of the matter is, when you go out into the district and you actually sit and listen, not coming in with preconceived notions, but just talk to those that are in the business. And I'm pleased, along with my friend from New Jersey, to be in this crescent in which we have a lot of the same kinds of companies and innovators. It's remarkable to me how many of them come and say that this is such a critical junction in which we are taking this action where we are killing innovation at a time in which those who are looking to break through with new technologies and new kinds of cures that the devices can bring are stifled at the most critical moment. This is so counterproductive for us to be labeling them. It's like putting sandbags on the wings of the Wright brothers as they try to figure out how to fly an airplane. It's at the worst possible time. And so I just, you know, my friend from Connecticut talked about this being, you know, what less filling, whatever the thing is. Well, this is the Marv Thornberry of ACA provisions that needs to be pushed aside so we can continue to protect innovation. And with that, I hope all of my colleagues will appreciate the impact this is having on real innovation and will support the gentleman from Minnesota's provision. Thank you.
Gentleman yields back the balance of his time. If there are no further amendments and no further comments, the question is on adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. No. In the opinion of the chair, the ayes have it. The amendment of the nature of the substitute is agreed to. I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 160 as amended to the House of Representatives.
The question is on favorably reporting H.R. 160 as amended. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. No. In the opinion of the chair, the ayes have it. The motion is agreed to. As the gentleman asked for a roll call vote. Roll call vote has been requested. The clerk will call the roll.
Mr. Johnson?
Aye.
Mr. Johnson, aye. Mr. Brady?
Aye.
Mr. Brady, aye. Mr. Nunes? Mr. Nunes, aye. Mr. Teaberry? Mr. Teaberry, aye. Mr. Reichert? Mr. Reichert, aye. Mr. Bustani? Mr. Bustani, aye. Mr. Roscom? Mr. Roscom, aye. Mr. Price? Mr. Price, aye. Mr. Buchanan? Mr. Buchanan, aye. Mr. Smith of Nebraska? Mr. Smith, aye. Ms. Jenkins? Ms. Jenkins, aye. Mr. Paulson? Mr. Paulson, aye. Mr. Marchant? Mr. Marchant, aye. Ms. Black? Ms. Black, aye. Mr. Reed? Mr. Reed, aye. Mr. Young? Mr. Young, aye. Mr. Kelly? Mr. Kelly, aye. Mr. Renacci? Mr. Renacci, aye. Mr. Meehan? Mr. Meehan, aye. Ms. Nome? Ms. Nome, aye. Mr. Holding? Mr. Holding, aye. Mr. Smith of Missouri? Mr. Smith, aye. Mr. Dold? Mr. Dold, aye. Mr. Levin? Mr. Levin, no. Mr. Rangel? Mr. Rangel, no. Mr. McDermott? Mr. McDermott, no. Mr. Lewis? Mr. Lewis, no. Mr. Neal? Mr. Neal, no. Mr. Becerra? Mr. Becerra, no. Mr. Doggett? Mr. Doggett, no. Mr. Thompson? Mr. Thompson, no. Mr. Larson? Mr. Larson, no. Mr. Blumenauer? Mr. Blumenauer, no. Mr. Kind? Mr. Kind, aye. Mr. Pascrell? Mr. Pascrell, no. Mr. Crowley? Mr. Crowley, no. Mr. Davis? Mr. Davis, no. Ms. Sanchez? Ms. Sanchez, no. Chairman Ryan? Chairman Ryan, aye.
Clerk will report the vote.
25 yeas, 14 nays.
There being 25 ayes and 14 nays, the motion is agreed to. The amendment is agreed to. Second order of business. 1 down, 9 to go now. Second order of business is H.R. 1190, Protecting Seniors' Access to Medicare Act. I will make a brief opening statement, then I'll recognize Mr. Levin or whoever his designee is. I'll go off script here, but this... Oh, I forgot. Yeah, I apologize. The committee will come to order. Please, those please leaving the room, please do so quietly. H.R. 160 is ordered favorably reported as amended, and without objection, I also ask that the staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days in which to file with the committee clerk supplemental, additional, dissenting, or minority views. The second order of business is H.R. 1190. This is the bill that would repeal the IPAB, or otherwise known as the Independent Payment Advisory Board. I don't know if there's another issue that highlights the difference in our philosophical approaches to governing than this one. There is a big difference in how we approach government and healthcare in particular, and this is probably the greatest example of that difference. Medicare is going broke. There's just no doubt about that. That's not a matter of opinion, that's a math problem. Whether it's the Congressional Budget Office or Medicare's own trustees, they all tell us about the unsustainability of Medicare. We've got 10,000 people, baby boomers, retiring each and every day in this country, and they will for 10 years at that rate. It's a pay-as-you-go system. Current workers pay current taxes for current beneficiaries. But we are not doubling the amount of workers coming into the economy like we are doubling the amount of retirees leaving the economy. Therein lies our problem. It's not a Republican thing or a Democrat thing, it's just a demographic thing, it's a math thing. Here's the problem. The Affordable Care Act put the Independent Payment Advisory Board in charge of Medicare. So what we have here is a board of 15 unelected bureaucrats in charge of hitting an annual quota to cut Medicare spending to conform to a cap. Now, the law says you can't change a person's benefits, but you just had to change provider reimbursements. Here's how this all works. They cut provider reimbursements. They deny access to procedures, which ends up cutting a person's benefits. There's no way around this. This is nothing more than an artificial mechanism to control prices, to put price controls on Medicare beneficiaries, which leads to rationing. Now, what's more insidious about this thing, the IPAB, is it is designed to circumvent the elected representatives of the senior citizens who use this program, Medicare. 15 unelected bureaucrats put their price controls in place. They go automatically into being, into law, unless Congress chooses on a supermajority vote to unwind it, to replace it. So, you know, I was born at night, but I wasn't born last night. Here is how this is going to go. And those of us who are talking about institutional knowledge, we know exactly how this is going to happen. What's going to happen is a member of Congress, say a person on the Ways and Means Committee, is going to see that the law requires they cut X billion dollars from the Medicare program in any given year. And if they don't like what IPAB does, then they're going to have to, with a supermajority vote, replace those cuts somewhere else in Medicare to some other providers that end up hitting the same beneficiaries. We all know what a member of Congress in that kind of a situation will likely do if history is any guide. They won't do anything. And IPAB will decide how this works. So what this bill does is it transfers the whole concept of government by consent of the governed, a important founding principle. It transfers the authority of writing these laws, of determining how these laws work, to a board of 15 people, 6-year terms, renewable. They can be renewed one more time, unelected. They don't even have to have a doctor among them to decide how to ration, how to price control health care. The way to solve this problem is by giving patients more power, not less, is by giving consumers more choices, is by having a collaborative economy where the providers of healthcare services, be they doctors or nursing homes or hospitals or ambulatory services or post-acute care providers across the spectrum, we all want them to compete against each other for our business as patients. We don't want to dictate how, when, where, and under what formula they have to construe their business models to meet some board's decisions on how to cap care. So of all the issues where we have just a deep difference of opinion on how Medicare ought to be governed, on how health care needs to be fixed, and how Medicare needs to be saved, we really do not think we should transfer the power of this committee, of this Congress, of the representatives of the people that we serve to a board of unelected bureaucrats who will ration care. And that is why we are pursuing the repeal of the Independent Payment Advisory Board. Mr. Levin, you're recognized.
I'll speak just briefly, and then I want to yield to Linda Sanchez. First of all, before we sound the fire alarm, I think we have a responsibility of indicating what kind of embers and flames there are. Medicare is solvent to 2030. And so I think we should not create within the constituencies that we represent a misinformation. Secondly, in terms of who's in charge of Medicare, this board, under the present predictions, its responsibilities would not be triggered until 2022. So I think we need to be careful when we say this is the issue of who's in charge of Medicare. And also I think we need to take into account the Republicans' approach to Medicare. And it said we should give patients more power, consumers more choice, but essentially that language often essentially leads to proposals to end Medicare as we know it and somehow devolve it into a very different system. So I think we need to beware of alarmist talk, though I think we need to face up to long-term solvency. And also, we need to be careful not to use this debate over IPAD, that's a legitimate debate, to essentially fail to disclose in any detail what would be the alternative to Medicare as we now know it. And often the proposals essentially would undo Medicare as we now know it. This is a legitimate debate. We had a similar debate over base closure. And some of the same statements were made regarding base closure. And I don't say that what is true there is automatically true for Medicare and the issue of IPAB. But I think we need to be careful before we make statements like we are transferring the charge of Medicare to some board whose responsibilities would not begin to occur for 7 or 8 years. And we would have time between now and then to see how the costs of Medicare were going. So far, the record is, because of ACA, Medicare is more efficient, cost-effective than ever. And we who support ACA are proud of the reduction in the rate of increase in costs that we have helped bring about because of ACA. I now yield the balance of our time to Linda Sanchez.
Okay. Thank you to my ranking member, and I want to begin by thanking the chairman for finally agreeing to tweak and not repeal the Affordable Care Act. I'm a strong supporter of the ACA, and I proudly voted for it when it came to the floor. And by all accounts, the ACA is working. It's reduced the number of uninsured individuals, it's lowered healthcare costs, and it's increased access to care. But even though the law is doing wonderful things, it doesn't mean that it's a perfect law. Despite its success, I think there are some minor fine-tuning points that we need to address, and one of them is the issue of the IPAB. And I've been pleased to work in a very bipartisan manner to solve a number of the issues within the ACA. But I think probably one that I think deserves our attention is, more than most, is repealing the Independent Payment Advisory Board. I think by repealing this, we can actually make the ACA stronger. And I know that Congressman Rowe has long taken the lead on this issue, and I'm happy to work with him on this. Now, the concept of IPAB was that it was created to reduce spending in Medicare if costs grew faster than GDP per capita growth plus 1%. The problem is that the board operates largely without congressional oversight or approval. If Medicare spending exceeds this target, IPAB is required to submit a proposal to Congress and the President that contains recommendations to reduce Medicare growth. These proposals are then submitted as legislation, which Congress must consider under an expedited or, for lack of a better word, fast-track process. And the statute specifies that Congress can't make changes that would result in Medicare savings that are less than the savings target that is set for that year. Now, as members of Congress, we are accountable for our decisions to our constituents back home. And I proudly represent the 38th District of California, and I try to do my best to look out for the health care of those constituents. Unfortunately, IPAB would usurp my ability to represent my constituents and give a board of unelected people the ability to make changes to Medicare without that same kind of accountability. My constituents work hard, they contribute into Medicare, and they want to make sure that they have affordable, quality care when the time comes for them to enroll in the program. And for me, I can't, in good conscience, give an unelected board the authority to make changes to one of the most important social safety programs in our country's history. I'd also like to just, if you'll indulge me, talk about the Congressional Budget Office's score for repealing the IPAB, because the CBO claims that this bill will cost $7.1 billion over 10 years, but they've also said that the board won't exist until at least 2022. Not only that, but the IPAB initially was never meant to generate any of the essential revenue needed for the ACA's core provisions, yet for some reason it's being treated as an essential funding mechanism, and I scratch my head over that. It doesn't make any sense to me. Because essentially CBO has somehow managed to come up with a 10-year cost calculation of a board that only exists as a figment of their budgetary imagination and given it a score to hedge their projections. Unfortunately, congressional leadership has taken CBO's budget delusions as gospel, and they've forced unpalatable pay-fors onto this common sense bipartisan piece of legislation. Go figure. In the 114th Congress, we finally have a chance to be proactive and to stop something before it becomes a problem. I implore my Republican colleagues to ensure that this legislation comes to the floor without partisan political pay-fors, because it's a bipartisan bill. That means there's agreement, there's a consensus, and it's my hope that we could actually pass this through the full House of Representatives. I hope that at the end of the day, good policy will trump politics, and that we can pass this common sense piece of legislation to keep Medicare in the hands of the people. And with that, I yield back the balance.
Let the record reflect that at the request of the ranking member, the chair indulged the gentlelady to go over the allotted time by 3 minutes for the opening.
Mr. Chairman, I appreciate those 3 minutes, and I'll give them back to you someday.
Well, we'll take you up on that. We'll find a way of taking you up on that. So the committee will now proceed to consideration of H.R. 1190. Without objection, the measure will be considered as read and open for amendment at any point. I'm now going to turn to Matt Hoffman, the staff director of the Health Subcommittee, to provide a brief description of the bill, and I ask that members hold their questions until after his presentation. Mr. Hoffman.
Thank you, Mr. Chairman. Ranking Member Levin. H.R. 1190 would repeal the Independent Payment Advisory Board created under Sections 3403 and 10320 of the Patient Protection and Affordable Care Act.
Any questions? Yes, gentlemen, have a question? Mr. McDermott is recognized.
Mr. Hoffman, would you explain exactly how this would work? How the IPAB would work, so we can understand what it is we're repealing?
So IPAB is required if the CMS actuary determines that over a 5-year rolling average that Medicare spending has increased a certain target. The IPAB is instructed to produce a proposal to reduce that spending. They do so in conjunction with MedPAC. That proposal is then submitted to Congress. And Congress can consider that measure in an expedited process. If they do not, that proposal is then resubmitted to HHS and the President to be enacted.
And then what happens after they submit it? What happens in the procedure after that?
It's submitted to Congress. Congress has an expedited amount of time to consider the legislation.
How much time?
A number of days. I think we have it 2.5 months, I think, is the max amount of time between the committees. There is also a procedure in which the leaders on both the House and the Senate side can call up the bill independently. So there are several different ways for which the proposal from IPAB can make its way to the floor.
So it's got 75 days. Is MedPAC elected?
No, it was created under statute years ago.
And do they make recommendations to us which we act on?
Occasionally, they produce annual reports that suggest various different changes to payment systems. We typically consider those, and sometimes they're enacted and sometimes they're not.
So we have the decision about whether an unelected group makes a recommendation to us that we can or we don't have to do what they say. We can say no, right?
Correct, but MedPAC does not have the expedited process by which, if Congress doesn't enact their policies, that they then become.
So it's the 75 days that seems to be the real problem, in that it's being done quickly. Is that it?
Well, that and that MedPAC doesn't have the subsequent ability to submit its payment recommendations to the President and the Secretary of HHS to be enacted if Congress fails to adopt their recommendations.
So you're saying that if we didn't adopt what this IPAB put together, it would go into law automatically?
Correct.
And that would have been done by a group that we stood back and let it happen, right?
If Congress chose not to act, correct.
Is that tell me how it works with the program with base closures, the BRAC proposal.
That is outside my specialty, sir. We work in the health subcommittee, sorry.
Okay, so you don't know if there's we've never done anything similar to this before in the government, as far as you know.
If the gentleman will keep the questions to the bill before us, the base closure bill is not in front of us. This bill is.
I'm asking, Mr. Chairman, if there's any precedent for what we've done here with IPAB. Is it something new that was created and there's no other? And it's right, he may not.
I'm happy to indulge the gentleman in the comparison between BRAC and this in after the walkthrough, if you'd like to.
Okay, I accept that. I was just wondered if he knew, and he didn't know. So
he's a healthcare guy. He's not an armed services guy.
Okay. Thank you, Mr. Chairman.
Mr. Doggett.
Thank you.
Do you have any questions?
I do. Thank you, Mr. Hoffman. Now, if I understand correctly, this independent payment advisory board exists in statute, but it doesn't exist today other than in statute, right?
Correct.
And in fact, the issues being discussed here, even if this independent board were going to take any action, we don't expect that to happen for another 7 years, right?
Correct.
It's not about a problem that exists today. It's a problem that might exist in the 7 years from now. With reference to the independent advice that we get in this committee now, to which Mr. McDermott referred from MedPAC, it is an independent body, as you mentioned, created by statute, and makes its recommendations usually each June. Those are usually designed to save taxpayers money and to not overpay for services. They made some recommendations last June concerning that. Some require CMS action, some require action from this Congress. How many of the MedPAC recommendations that related to overpayments have been adopted by this Congress or considered in this committee since the June MedPAC recommendations last year?
We haven't considered any since last June.
Haven't considered any of them. And so one of the reasons for this commission relates to, and I certainly don't subscribe to all the recommendations necessarily they made last year or the years that I served on the Health Subcommittee, but this committee has faced challenges when some of the interested groups came forward and offered their explanations for why MedPAC was wrong about saving money on this program. And I think the independent board here is an imperfect answer, but it seems to me we need some better way to deal with rising costs in the system. That was one of the criticisms of the Affordable Care Act.
Gentlemen, this strikes me as appropriate comments for moving to strike the last word when we're in debate.
I just have a couple more questions for him. Okay. My question is there through this bill or through any companion legislation, an alternative that is being advanced to the Independent Payment Board to deal with excessive cost to taxpayers?
The legislation, H.R. 1190, just repeals the Independent Payment Advisory Board as created under statute.
Provides no alternative. And also with regard to cost, if I want to do more for foster children, I found that there was objection in this committee even to a few $1 million additional cost. This is a cost that has been scored at $7 billion. I understand you're not required to have a pay-for in this committee. Can you or the chairman give us an idea of how this $7 billion, where we will get the $7 billion from to stay within our existing budget rules?
The legislation, H.R. 1190, does not contain an offset.
All right, Mr. Chairman, can you give us any insight into how this $7 billion? I know if I were trying to get $7 billion to help poor kids get access to insurance in Texas, it would be a struggle to come up with any way to pay for it. How is it that we will pay for this $7 billion to address this problem that is 7 years away, but nevertheless has a cost of repealing the provision?
That's not in the scope of the committee or the scope of this markup.
All right, well, could you, whether it's within the scope of the markup or not, it could affect our votes. Do you have any, can you give us any guidance whatsoever of where the $7 billion would come from, or whether it would just, that $7 billion would simply be ignored by making an exception?
I would tell the gentleman that the bill before him is the bill that he will be voting on in this markup, and then he'll have to wait and see in what context the bill comes to the floor and make his decision accordingly.
So it's kind of a hide and seek, vote blindly type approach. I thank you.
What's in front of you right
for your
now.
answers.
Mr. Rangel.
Mr. Hoffman, could you describe the qualifications of the board members in order to determine their background in reaching these decisions?
I believe the background of the boards cover all stakeholders that are involved in the healthcare industry, from patient advocacy groups to providers to hospital clinicians.
What makes them uniquely qualified to determine payment in any particular procedure?
They have background in both on the payment side and on the procedure side.
Are the required backgrounds written any place so one can? The chairman made specific mention of the fact that none of them are or required to be medical.
Yes, according to statute, the appointed membership of the board shall include individuals with national recognition for their expertise in health finance and economics, actuarial science, health facility management, health plans and integrated delivery systems, reimbursement of health facilities, allopathic and osteopathic physicians, and other providers of health services and other related fields who provide a mix of different professions, board geographic representation, and a balance between rural and rural representation.
Well, in language that we could understand, could you share with us why we should have confidence in the appointment of people who are described by that gobbledygook that you read? Could you say why you would feel very comfortable in having a panel like that determine the payment of a procedure that you may be subjected to in a hospital or by a doctor? What would make you feel, who are these people, besides what you've read?
I'm not sure that's the correct question to ask.
Well, why don't you reframe the question for me? I'm trying to find out how these people determine the cost of a procedure. So you can word it any way you want, but you're the one that
I'm not going to reframe your question for you.
But you said that they're not doctors. How do they know? So who are they?
That's a good question. I don't think Mr. Hoffman has the answer for
Well,
you.
if he hasn't got the answer, who would have the answer, Mr. Chairman, so I can...
If I recall, the gentleman was chairman when you wrote the legislation. Why don't you ask yourself?
Well, we were trying to cut the cost. We were trying to cut the cost, and the administration said they had the people that they were going to put on the board, and then a lot of people on your side screamed that they were the death panel and that they were trying to decrease the services that are there. And so I want him to be able to show that these people know what they're doing when they do it. But
Well, Erin hasn't left yet. Why don't you ask her?
no, but I think that the regular procedure would be to ask the administration's people here, but obviously Mr. Hoffman is not able to answer. It's all right with me.
I can read from the bill.
No. I just thought that perhaps you had a feel that would make the chairman feel more comfortable that these people were competent enough to make decisions that would not adversely affect a patient's quality of service. But you're not, and I'm sorry I raised the question to you.
All right. Mr. Neal, do you have a question?
Thank you, Mr. Chairman. Mr. Hoffman, are MedPAC recommendations binding?
No.
How would you construe them for the committee?
They are recommendations proposed to Congress on payment changes to all hosts of Medicare programs.
And how might you differentiate that from IPAB?
MedPAC doesn't have an enforcement mechanism if Congress doesn't consider their proposals.
So it's almost like binding arbitration. You go to the last best offer, and then IPAB makes the decision?
If Congress doesn't adopt their recommendations.
And what would be the procedure for adopting the IPAB recommendations?
Congress would have to bring the bill to a floor and vote.
And how many votes would be necessary?
One in the House and one in the Senate.
No, I understand. Thank you. I understand that. Much as I disagree with the Senate, I even understand that.
Yeah.
Yeah.
The question is, the supermajority occurs afterwards.
Exactly. That's the point that I would like the witness to offer, if we could, Mr. Chairman. Supermajority.
Yes, correct.
And how many votes would that be?
2/3 in the House.
2/3. We'll leave the Senate out for the point of this discussion. Thank you. Thank you, Mr. Chairman. Is it all right if I could go on at this point?
Please.
The difference here is I was against IPAB from the beginning, and I'm against it now, and I'm going to vote accordingly. It is the outsourcing of congressional responsibility. Now, before the other side offers the affirmative as they are doing, please consider that when it comes to positions like the balanced budget amendment to the Constitution.
Mr. Neal,
Mr. Chairman, you said that I could go on.
Are you asking the staff director
I asked if I could go on, and you said please.
Yeah, with questions. Not with
When would be appropriate for me to give you a constitutional analysis of the position that is being offered by the committee, Mr. Chairman?
Gentlemen, if the gentleman will yield, when we're done with the walkthrough, then feel free to strike the last word and speak your mind.
It strikes me that I was doing pretty well, and that's what the chairman objects to.
Let's get through the walkthrough. Are there any other questions of the staff director of the Health Subcommittee as to the content of this bill? Mr. Kind.
Thank you, Mr. Chairman. Mr. Hoffman,
That's
now,
another way of saying.
how does IPAB get constituted? Am I correct in saying that there's a confirmation process on the Senate side for those who want to serve on the board?
Correct.
Roll, right?
Well, Mr. Chairman, I would assume that if the authors of IPAD wanted to come up with a clever way of killing it before it even has a start, you just subject it to confirmation hearings in the United States Senate these days, and that will kill it. So this legislation is superfluous. It's not going anywhere anyway. And I yield back.
Yeah, so I got to get through the walkthrough. Are there any other questions? If there are no further questions, are there any amendments? If there are no amendments, do any members before the committee wish to strike the last word?
I'd like to strike the last word, Mr. Chairman.
All right, good. Mr. Neal is recognized.
I thank you very much. Now, in deference to the last question that was raised, we can't say that we're for repealing the medical device tax, but we're seeking greater reimbursements from the federal government, and we want IPAB. And the politics work. The problem is the policy doesn't work. So back to the point that I raised before. So our friends on the other side who frequently will reference the notion of suggesting, do you have the Constitution in your pocket? So we've watched now the outsourcing of congressional responsibility on a series of issues. We hear about the balanced budget amendment to the Constitution. My God, we should outsource that responsibility, even though Bill Clinton proved with the help of George Bush I that you can balance the budget. We will hear that we should simply give up congressional earmarking, despite the fact that The Constitution says that Congress is mentioned as the first branch of government in Article 1 to determine spending. So we transfer that authority to the executive, Republican or Democrat, and we give up the prerogatives that were constitutionally protected for good reason, and that was not to create a superpower at the other end of Pennsylvania Avenue. And then we hear during my time in Congress that we should, well, just embrace the line item veto to the Constitution so that we can further erode congressional responsibility. And then we complain about the inability of Congress to get things done based upon talking points as opposed to legislating. The IPAB was a bad idea at the outset. It's a bad idea now. The idea that we would have an independent body that is simply confirmed by the U.S. Senate to then make determinations on what hospitals in Massachusetts ought to receive for reimbursements, it ought to be based upon the knowledge and the innovation that has been suggested. Now, I would also dispute what was offered a while ago when it said that California was the center of innovation in America. Kendall Square in Cambridge, Massachusetts is the center of innovation in America. It has the highest concentration of R&D in the world. And the point that I raise here is that it's inconsistent for our friends on the other side to shepherd the argument about protecting constitutional prerogatives and then embrace some of the budget schemes and opportunities that they do. So I would hope for some greater consistency as you watch a number of Democrats who are prepared to vote to get rid of IPAB when you hear these arguments that are brought to the floor to get around the legislative process. And I offer that, Mr. Chairman, in a very sincere vein, where there ought to be an opportunity for us to discuss some of the powers that we have arbitrarily given up to the executive and then complain that the executive is too powerful. I yield back my time.
Gentleman yields back. Got a pretty good list here. Mr. Pasquarello, do you move to strike the last word?
Thank you, Mr. Chairman.
Gentleman's recognized.
Yes, I do. Mr. Chairman, the Affordable Care Act did not just give us one tool to bring down health care costs. It provided us with an array of tools we can use depending on the circumstances. It's been pointed out by many of us in this room over the last several years how critical it was that health care reform include the cutting-edge delivery and payment reforms that it did. But I've never believed that the Independent Payment Advisory Board will be effectively able to fulfill its stated mission of cost containment. I have concerns with how IPAB will operate and that it gives up important congressional authority over payment. That is why I am a co-sponsor of this bill and will support it today. Let us be clear that IPAB was originally designed to protect beneficiaries. Despite what my friends on the other side would have you believe, it is the Republican budget's Medicare voucher plan that would end Medicare as we know it. So while we may be talking about repealing IPAB today, we should not lose the big picture. The ACA was the beginning of entitlement reform. When Congress considered this legislation last year, many on the other side presented an offset for the cost of the bill, wanted to change medical malpractice. We can discuss that, but I simply cannot support what was presented last year. It's my hope that my colleagues on the other side of the aisle will work with Democrats to find an agreeable offset for the bill. I will support this legislation. I think it's very necessary. Thank you. Yield back.
Gentleman yields back. Ms. Jenkins, do you seek to strike the last word?
Yes, thank you, Mr.
Gentlelady is
Chairman.
recognized.
I appreciate the work the committee is doing on this important legislation. Legislation to repeal IPAB has consistently drawn bipartisan support, and it's time to repeal it. IPAB was created as part of the President's health care law in a way that allows it to supersede Congress. It bypasses the normal legislative process by mandating Medicare spending and budget decisions and forcing a congressional veto. I fear that IPAB's cuts could be based on the bottom line rather than on efforts to truly improve efficiencies and find savings without compromising patient care. There is much that can be done in the Medicare space to improve quality and reduce costs, and many of these efforts will be explored by the committee and this chairman in the coming months. But allowing unelected, unaccountable bureaucrats to make these decisions in our place is simply bad policy. I urge my colleagues to support this legislation, which repeals the IPAB, and I thank you and yield back.
Mr. Thompson, are you? No. Mr. Becerra, you move to strike the last word. Gentleman is recognized.
Thank you, Mr. Chairman. As I listen to this, it strikes me that I wonder if this will be the same debate that we'll have and the same comments that we'll hear when it comes to whether there should be a fast-track authority that concedes Congress's powers to make decisions on trade legislation rather than have just one up or down vote. And if you don't have the vote, then the non-congressional negotiated trade pact becomes maybe law not just of the land, but that may even supersede our own laws of the land. And so it strikes me as interesting that while we are talking about being covetous of our congressional powers to do reform, this place probably has one of the worst track records in getting reform done. I was never a supporter of IPAB myself because I do believe that we should have the wherewithal to get things done. Unfortunately, we've seen Congress break down dramatically over these last few years and really not accomplish a whole lot. I think Mr. Doggett brings up something that many of us had not really thought that much about, and that's the fact that when we have had independent bodies provide us with some guidance on how to better reform and save money for the taxpayers, that doesn't automatically take effect and requires congressional action. Too often, Congress hasn't acted, and nothing gets done, perhaps at the expense of the taxpayer. So I'm a little torn on this because I'm not yet convinced, like many of my colleagues, that IPAB is the best way to go about trying to help us save the taxpayers money and still make the Medicare program run as efficiently as it should. But at the same time, we run into this roadblock again, that is that we would be adding $7 billion to the deficit, borrowing money from China, or telling Americans that we'll have to cut some other important service or program that they depend on in order to do this. And so without some pay for, without knowing how we would move forward with this particular legislation, I find myself in a position of saying that I will be voting against it. So I appreciate the debate, but as I mentioned earlier, I'll be interested to see how many people defend Congress's prerogatives to make these kinds of decisions left to us under the Constitution when it comes to a vote on trade promotion authority. Yield back.
Mr. Brady, you seek the
I do
last word.
seek strike the last word.
Gentleman's recognized.
The comparison between setting the trade rules and IPAB is beautiful because they're exactly the opposite. Trade agreements are simply a law proposed by the president that we vote up or down with. It does not become law unless Congress approves it. IPAB is just the opposite. These are payment cuts made by 15 unelected bureaucrats that, for all intents and purposes, become the law of the land unless Congress creates a supermajority to block them. IPAB is the Iran nuclear agreement of health care. It goes forward unless we somehow figure out a way to stop it. My question is, why would anyone on this committee oppose this bill? Why would the Committee of Jurisdiction, charged with handling the very delicate issue of saving Medicare for the long term, balancing never enough money for growing health care needs and doing it in such a way that our seniors get access and those dollars are stretched to get them? Our committee, yes, MedPAC recommends to us And then after a lot of consideration and thought, we take action. Sometimes CMS makes payment decisions, and we will react and give thoughtful consideration and take action on it. My question is, well, the question before us today is, who has the power to make the decision? Is it IPAB or the key committee of jurisdiction, weighed with the weight of making the key decisions on how payments are made in Medicare?
Would the gentleman yield?
Not at this time. IPAB doesn't ration care. It simply rations the payment for the care, which is exactly the same thing. This committee does not support rationing in any form or fashion, and we have worked hard in a bipartisan way to change the reimbursement schedules for our physicians, to make sure they'll treat our seniors, and we find a good way to go forward. We are proposing changes in hospital payment, resolve that demolition derby of inpatient versus outpatient care, and post-acute care, nursing homes and rehabilitation and all that, again, so we can line everything toward the patient, not toward Washington. IPAB has none of those considerations, and that group has none of those considerations to think about. But as elected leaders who work very hard to serve on this committee, which has the primary jurisdiction for changing payments in Medicare, this seems to be exactly opposite, IPAB, of anything, Republican or Democrat, that these members on this committee should be supporting. So this committee should have that power. Our Democrat friends, I know there's some weird sense of authorship in the Affordable Care Act, but our Democrat friends repeatedly have proven and said they would, rather than repeal the Affordable Care Act, would like to improve it. Here's an opportunity to improve it in a way that returns the jurisdiction of these sensitive issues to this committee, and I urge support.
Would the gentleman yield?
Yes, sir.
So, Mr. Brady, a question. My understanding was on the Trade Promotion Authority bill that we're going to have before us at some point soon, that if it passes, that any trade bill, Trans-Pacific Partnership, for example, which came before us, we would have a certain amount of time within which to have to vote up or down that legislation. And
with a simple majority.
With a simple majority. So the difference is then that IPAB requires a greater standard for Congress to undo.
No, big difference, if I may reclaim my time. The big difference is the IPAB cuts go through unless Congress can stop it. A trade agreement does not unless Congress approves it.
So,
night and day difference.
But it does require us to vote affirmatively against the trade.
No, it is simply a law. It is simply a law. It is not a treaty. It's not an agreement. It is proposed law to change America's tariffs and America's rules, and if we vote it down, it stops. IPAB goes forward unless we somehow garner a 2/3 in this partisan atmosphere to stop it.
Right, and trade goes forward unless we...
No, trade does not. This trade is a proposed law that either chamber can kill, period.
But we have to vote one way to kill it, otherwise it takes effect.
No, exactly opposite. I know you know this, Mr. Bracero. I know you know this issue. This is a proposed law and nothing more.
Time for the gentleman has expired.
Thank you for yielding.
Mr. Blumenauer, do you seek strike last word? Gentleman's recognized.
Thank you. I appreciate the chairman launching us in this discussion, talking about Medicare going broke, and I know he has been deeply concerned about this in times past. But I think it's sort of an interesting context. The IPAB has this invisible hand which may maneuver Congress into acting. But it's interesting that my friends in the majority have been very comfortable with the invisible hand of insurance companies or outsourcing things in Medicaid to state legislatures to impact ways to control costs. It's, I think, interesting that the proposals that have been offered up would rely on these invisible hands of other mechanisms to reduce costs without explicitly saying exactly what they would, just relying on the market or whatnot, and having so little confidence in it that they've always been delayed 10 years into the future, that it would never impact any seniors now or tomorrow or for 10 years. Why would any Armed Services Committee agree to have a base closing commission that would invade their turf? Well, I think history has shown that Congress, unfortunately, often lacks the fortitude to step up and take action directly. What passes for reform is passing it off to insurance companies or state legislatures someplace else. I would respectfully suggest that it is far better for us to at least have a backstop, which Congress has the authority to replace if we do our job. Now, if you are concerned that it's a supermajority, rather than repeal the IPAB, why don't you just adjust that and make it a majority? My concern is that we're never willing to make hard decisions. And I'm perfectly willing to admit that at times when Democrats were in control, people did not rush to embrace all the MedPAC recommendations from those 17 unelected bureaucrats who were actually pretty spectacular people who did the hard work, did the research, came up with reasonable recommendations. My friend, Mr. Kind, pointed out that we've had over $750 million of potential savings identified, but that's uncomfortable because we're going to step on somebody's toes. So what's happened year after year after year is that we've made little fixes and adjustments and ducked some of the big issues that have been advanced to us. This is a backstop. Is it the best? No, not particularly. I mean, it's sort of in keeping with how I would characterize the Affordable Care Act. It's a B-. It wasn't great legislation, and we got what we got because of complete collapse of the legislative process in the Senate. So we had to backdoor it through reconciliation. And there's stuff in there I don't agree with. But ironically, it's doing a pretty good job. Healthcare costs are down. The economy hasn't crashed. We're watching some fascinating experiments moving forward. And we're going to talk about some refinements here in a few minutes that are basically bipartisan and reasonable. And I think we can do a lot more of that with this committee going forward. But just like we'd never close a base without a base closing commission and unelected bureaucrats, it's really hard. And it's been hard for this committee to do its job dealing meaningfully with MedPAC recommendations. I personally am not supportive of eliminating it, but if you want to amend it to make it just a majority so that you don't have a supermajority and it's not on a fast track and you've got all these problems, I think that's a great idea. Let's make it more responsive, but let's not remove a little pressure for Congress to do its job. It's too easy for us not to do our job, whether it's reforming Social Security or it's dealing with ways to reform health care.
Time for the gentleman has expired.
Thank you, Mr. Chairman.
Mr. Larson, are you moving to strike the last word?
Move to strike the last
Gentleman's
word.
recognized.
Well, thank you, Mr. Chairman. And, Mr. Chairman, thank you again for providing this committee the opportunity to get involved in a dialogue that sometimes goes beyond even the legislation that's before us. So let me say at the outset how I strongly support the initiative of Representative Sanchez and want to associate myself with her remarks, the remarks of Mr. Neal. And just to go on to make this comment, I said earlier, let's be honest. If we had a show of hands around the table and said how many people on this committee are in favor of repealing the Affordable Care Act, I'm going to venture a wild guess that a number of hands on your side of the aisle would go up. Exactly. And so Mr. Teaberry makes the point in saying that, but listen, is any individual proposal that emanates from this committee put forward in a manner that's not constructive or without integrity? No, including Mr. Polson's proposal and Ms. Sanchez's proposal, which there will be wide agreement on, and a number of bills that will follow all of this that there has been large bipartisan agreement on. So where are we as a committee? And why is it, and this is what the American people want to know, why is it, as Mr. Kelly says, Republicans aren't opposed to people. Republicans, as Roosevelt once famously said, aren't frozen in the ice of their indifference towards the public. You care about citizens as much as we do. So why is it that we keep talking past one another and we can't come up with a solution as it relates to making sure that people get decent, affordable, accessible health care? As flawed as a bill may be or have been, it is working on behalf of the people. What they want is to see it work better, not to demagogue it and say it's got to be repealed entirely without any kind of replacement. And therein lies the rub on the committee. I suggest, again, and I make the plea, Mr. Chairman, that we sit down in groups, not unlike we did with tax reform under Mr. Camp, and whether it's the highway bill, whether it's the Affordable Care Act, that we, this committee, can come up with a proposal. Or as sure as we're all sitting here, we're going to get an omnibus bill jammed down our throats that maybe a few people will have had input in, but is going to be forced on us to vote sometime in November and December. Maybe I'm wrong about that. Maybe we'll go to regular order, but not in the 17 years that I've been in Congress have we done that. And that's what we're facing against. So both sides can have their strong philosophical concerns. We can raise them. What we should be doing is clamoring for regular order, sitting specifically as a committee to make sure that we can get to resolutions that best help the people. I'm supporting Representative Sanchez because I do believe, as the chairman has said, this bill is important and goes a long way to improving the Affordable Care Act. I am concerned, as with other bills, about the unpaid-for nature of so many things that can hurt our ability to assist the American people, which I do believe everybody on this committee is concerned about. Thank you, Mr. Chairman.
Gentleman yields back. Mr. Doggett, is he? Did he leave? Okay, he lost his chance. Dr. McDermott, did you want to move to strike last word? Gentleman's recognized.
Thank you, Mr. Chairman. Before we started the debate on the Affordable Care Act, I sent a memo to Ms. Pelosi and suggested that we needed a health committee in the Congress. 1/6 of the economy. When I started in this place, about 12% of GDP was spent on health care. We're now at 17%. It continues to go up. We're looking at 17% of the country's wealth is spent on health. And the jurisdiction is divided between the Ways and Means Committee and the Education and Labor Committee and the Energy and Commerce Committee and the Judiciary Committee. And we have a great deal of difficulty dealing with things when it can fall into the jurisdictional fights among the Congress. Now, as I listen to this debate, Mr. Blumenauer came close to what I really believe is going on here. Back in Athens, before the present era, they had a democracy. That's where democracy came from. And there were two groups of people. There were the idealists, those who believed in what ought to be, and they held up the idealists, and they had great ideas. And then there were the second group, which came to be called the cynics. Now, in those days, the word cynic really stood for realist. And anybody who looks at the Congress today and believes in ideals, that the Congress will take up these issues and deal with them in a forthright manner is living on some other planet. The people who put this bill together were put together by realists who know the difficulties we have in making cost-cutting of any sort. Now, somebody said down, I don't remember which side of the aisle it was, said, we'd never ration in this committee. Anytime you cut, you are rationing. And so every time we try and make a cut, we tried on Medicare Advantage, and everybody said, oh, you're cutting, you're rationing care to the seniors. And those kinds of debates rage back and forth here. And so the people who put this bill together said, why don't we have a committee that can make some recommendations? Now, I've heard more people rage around here about deficits and throw themselves on the floor and tear their clothes, and America's about to end because we have deficits and we can't figure out how to do anything in this country. What's amazing is how actually creative the Congress has been over the years. Well, we set a group off, and they were called Simpson Bowles. That's how they got to be known. They came back with a great plan about how we should deal with the deficits that face our country that was going to lead to the demise of democracy that we all know, and the dollar be devalued and we'd fall in the esteem of the world. Did we deal with Simpson Bowles? No. The idealists who put that together never realized they got to put some mechanism by which the Congress is going to have to deal with something. And my belief is that this proposal, whether it's the right proposal or not, we're a little like one of those councils that's called by the Vatican where all the heads of the church get together and discuss how many angels can dance on the head of a pin. We're talking about something that's going to go on in 7 years. And everybody's already wringing their hands over being jammed against the wall. Everybody here will have to be reelected 3 more times before they come to that date when they finally have something put there that they have to vote for. The question really is, and I'm going to vote for this because it's the only thing we have. I'm too much of a realist to accept that the Congress will deal with making cuts, because I've watched us. We're great on increasing access. That's what the president had in front of him: create access and control costs. And if we can all figure out how to get more people in, the question is, how do we control the cost? Or don't we really care? Maybe we don't care. And I think a vote here is a statement of saying, well, I'll leave it up to the Congress. I know how they'll operate. I know how they operate now. We can't pass a bill on transportation in this country. We have a system that's going to come to an end in August or sometime because we don't have any money. And yet we say, well, that's just the way it is. I guess we don't need roads in this country anymore. I think the health care issue is going to be a problem cost-wise as we go down the road. We've got to have some mechanism, so I support this.
Gentleman yields back balance his time. Mr. Roskin, do you seek the last word?
Mr. Chairman, I move to strike the last word.
Gentleman's recognized.
Okay, so for everybody who says Congress cannot get a thing done, spare me. The doc fix was part of our collective thinking that said, we cannot fix this, it's impossible, it's a bridge too far. So what happened? 17 different times it got patched along until people got sick of it. And what happened? Everybody came together, donkeys and elephants, liberals, conservatives, our leadership, based on a lot of pressure from a lot of us, because we were all tired of going to our providers and saying, we're going to get this fixed in another little bit. Everybody got tired of it. And what was the remedy? A fix. Signed into law by the President of the United States. I'm on a riff. I'm not going to yield. Signed into law by the President of the United States. And 392, I'm told, nearly 400 people in this House agreed with that. It's like, come on, we can do this. Now, Mr. Chairman, I've got good news for you. The good news is, if you have insomnia, I've got a remedy. The remedy is read the Affordable Care Act, and it's right here. And I promise you, If you're an insomniac, you start going through this page by page by page, and it will put you to sleep. But I urge caution. Skip page 420 in this version, because on page 420, there's something that's discussed as it relates to IPAB that I don't think we've talked about yet today, and it's this: a limitation of review. Now, that's scary. That's jarring. That's disquieting. And that should wake you up if you're a member of Congress. And here's what it says: there shall be no administrative or judicial review under Section 1869, Section 1878, or otherwise of the implementation by the Secretary under this subsection of the recommendations contained in a proposal. Period, paragraph, end of letter, done. So you know what happens? We yield. We don't just yield our authority, which is ridiculous. We yield the ability of a co-equal branch of government to review this. Think about that. I don't know the base closure background, but if there was no judicial review, there was a mistake, and I'm sensing an opportunity. I'll yield to the gentleman.
It was proposed by Dick Armey as a freshman member of Congress to move around the logjam that had been created sometime in around maybe 84 or so, 85, and it became the law of the land. And you can see how difficult it is now to even get the BRAC up and running, never mind have a vote on actual base closure.
So reclaiming my time, and I thank the gentleman, look, this is a serious thing that IPAB has done. It's in the law now, and we have all, as members, we've interacted with the administration on different things, past administrations, current administrations notwithstanding, and trying to get the attention and trying to move someone and trying to get someone to revisit a rule or whatever it happens to be. At least you've got the threat of a possibility of review, but not with this. Not with this. In this case, we have given that up. And I think what we need to do is to reclaim that authority. We're able to reclaim that authority, not just for our review. And look, we've got the capacity to deal with these things. But also it's very important that there be judicial review. So with that, Mr. Chairman, I urge the passage of the bill, and I yield back my time.
Mr. Kind, you move to strike the last word.
Yes, Mr. Chairman.
Gentleman's recognized.
Thank you, Mr. Chairman. Mr. Chairman, I view the IPAB Legislation Commission as in the category of when all else fails. This is the default option. When it's determined that the rising cost of health care is exceeding our ability or our willingness to pay as a nation, then IPAB is invoked. And as Mr. Doggett pointed out a little bit earlier, this is barely on the horizon right now. It's 7 years out at best. And that's because since passage of the Affordable Care Act, we've had the lowest expenditure in health care on a per capita basis and GDP in the last 60 years. Lower than most of our lives, or at least some of our lives on this committee. And there's a lot of cost containment measures in the Affordable Care Act that are working right now. And if the other side would stop opposing it so much and start working with us on those cost containment measures, then IPAB is a complete irrelevancy. We don't even have to get to that place of having to make those type of tough decisions. The accountable care organizations, the medical homes, the bundling arrangements, the innovation center, looking at different payment models. And I know Chairman Brady also embraces the idea of payment reform, so we get to a value or quality-based reimbursement system rather than the fee-for-service or volume-based system we have now. I think everyone here understands there's still way too much utilization in the healthcare system. And we're still spending way too much and not getting the results or the quality of care that Americans deserve. And yet this commission is another attempt to try to rein in healthcare costs. And we know that as far as our unfunded liabilities in the future, it's not defense spending, it's not Social Security, it's not even interest on the debt so far. It's rising healthcare costs, which is the great challenge that we face with our budgets. And those are the tough decisions that we have to make. And unfortunately, I wasn't born the other night either. And I've been on this committee long enough and a member of this Congress, so I don't have a lot of institutional confidence that this Congress can rise to the occasion. and make some of those tough decisions and say no to the vested, powerful, special interests that are knocking on our doors every day around here. Mr. Roscom cited the great bipartisan achievement of SGR repeal. Now, I supported it. I got sick like everyone else did with 17 continuances. But it was unfortunate that the Republican-led Congress didn't try hard enough trying to find a bipartisan way to pay for it. It was only $80 billion in offsets. It was $140 billion in deficit spending to repeal SGR. And that's the great achievement for health care reform that we've made so far in this session of Congress. And if that's going to be our track record, there's no way in the future we're going to be able to make tough decisions to rein in those health care costs and get our structural budget deficits under control. I know it's something that the chairman of this committee has had a strong interest in for years, having been chairman of the Budget Committee. There's a reason why we had a BRAC commission, because of the inability of members of Congress to say no to local parochial interests. And that's just as strong and just as true in the healthcare field, too. And I'm hoping we can move forward in the future years, work on further bipartisan cost containment measures, so that IPAB is just a figment of the imagination, is never necessary to even invoke. But the truth is that given the confirmation process in the Senate and who's in control over there, IPAB is never going to be a creature that's created around here, and I think we all recognize that as well. But if history is any guide, we don't have a very proud track record to point back at for cost savings within health care. We made some of those tough decisions in the Affordable Care Act. We cut back on overly generous subsidies to the MA plans. The other side, you guys use it as campaign fodder out there year after year, and yet somehow it made its way in your own budget resolutions where you adopted those cost savings. And I will assume that they're the same cost savings that we put up and we voted on until you show different offsets to come up with the $750 billion that you include in your own budget resolution today. That's a direct result of the Affordable Care Act. So let's be honest around here. This institution doesn't have a lot of credibility when it comes to saying no to some of the powerful interests that exist within the healthcare field. IPAB, at least, is an attempt to force Congress's hand, where they come forward with recommendations and say, fine, you show us that you can do better, and none of this will take effect. That's all that IPAB is saying here. It's putting the gauntlet down on us and giving us the time for us to come together in a bipartisan manner, to come forward with more acceptable offsets or reduction in spending in health care than what they came up with. And I don't know why we need to be so frightened for that proposition. And it's for that reason I'm going to vote no on this repeal legislation. I yield back.
Gentleman yields back. Ms. Black, do you move to strike the last word?
I do, Mr. Chairman. I
Gentlelady
move
is
to strike the
recognized.
last word. Thank you, Mr. Chairman. There's been a lot of good discussion about the kinds of things that we can do to reduce the cost of care. Many of those are in this markup today, if we can get to those. And they are certainly things that we need to do. They're needed to be done not only just for saving costs, but also to increase quality of care. And I look forward to getting to the discussion on the remainder of these bills. However, this discussion right now is about controlling costs under the IPAB. And I'm glad that my colleagues on the other side of the aisle agree with us in many of these ways, that we shouldn't have 15 unelected bureaucrats making the decision about controlling those costs and saying what should or shouldn't be given to a patient. It also puts a government control there that takes away our responsibility and our voice in what the congressional responsibility is in this topic. And so I'm glad to hear that that's being acknowledged. It also limits enrollees' choices and doesn't give our seniors, which is so hard, and having been a nurse for over 40 years and working with people in long-term care, I can tell you that one of the things that I heard so many times from people that I took care of is just because you get older doesn't mean you can't make your own choices. And they told me consistently how they were discouraged that people told them what they should or shouldn't do. And once again, here's government control to say what you can or cannot have and deny services to our seniors. So one thing that hasn't been mentioned here is something that we put on the table several years ago, and that is the premium support. Now, let's contrast premium support with IPAB. In premium support, which is not voucher, by the way, and I wish that people would know the difference between a premium support, which is used in our own healthcare system of what we get as members of Congress or employers give to their employees, where the premium goes to the insurance company. And premium support, this is not a voucher program, but just that. It is where there is guaranteed coverage, regardless of pre-existing conditions. Those who can at least afford it will have their premiums totally paid for. But what this does do is it gives patient control. It allows those that are in the Medicare system to decide, do they want to go into the free market or do they want to stay in a government fee-for-service? It also increases market competition. Anytime you have market competition, you also have more innovation, you have more choices, it lowers the cost. So premium support puts this into the hands of the very people that are going to be using those services, as opposed to IPAB that will have a government, 15 bureaucrats making a decision. No, you can't have that service. No, you must take this. This is what we tell you that you're going to do. So I would encourage my colleagues on the other side to look once again at what has been proposed in premium support. It really is the future of what we need to do for our seniors to say, you are in control. If you like that program that's offered, that's a program for you. If you have less health care conditions that need higher cost of coverage, you can get in the senior sneaker program. You can have your exercise program at the YMCA paid for by the government. And that is really where we need to go, is give them more choice, put it out to the market, allow the market to work, bring down the costs, and get government out of the way of our seniors and let them be in control of what's best for them. Thank you, Mr. Chairman. I yield back the balance of my time.
Yields back balance for time. I understand that there are no other further members who seek to strike the last word. I will move to strike the last word for a few brief moments. You know, I think the quality of this debate shows that this committee is up to legislating on health care. I thought these were all very thoughtful comments. You know, Mr. Kind made some really good points. We have to deal with these interest groups that come at us on this committee. The Medicare numbers are daunting. I mean, it's vicious math. And so we, as a committee, are going to have to get on top of this issue. And the sooner, the better for everybody involved in the country. Dr. McDermott invoked Athenian democracy and leaders. I would argue that there's a little too much Plato in the Affordable Care Act. We need a little more Aristotle. And why don't we figure out how to do that? I think, no, I'm not trying to trigger a comment from you on that.
I just want a further explanation. I'm not asking.
Oh, do you want to get into this?
Plato and Aristotle?
Yes, yeah.
Okay,
This is too platonic, if you ask me.
The unexamined life, Mr. Chairman. The unexamined
We don't have the kind of time Demosthenes apply to debates, all right? So the point is, I think this is a good debate. We all have spent a lot of time on this issue, and we're going to need to. And we're going to need our level of legislating to go up to a much higher level than it has been in the past because of the enormity of the challenges in the future. And so with that, I yield back the rest of my time, and let's call the vote. There are no further discussion. I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 1190 to the House of Representatives.
Questions on favorably reporting H.R. 1190. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it. The motion is agreed to.
Recorded vote.
Yep. A roll call vote has been requested. The clerk will call the roll.
Mr. Johnson?
Aye.
Mr. Johnson, aye. Mr. Brady? Mr. Brady, aye. Mr. Nunez? Mr. Nunez, aye. Mr. Teaberry? Mr. Teaberry, aye. Mr. Reichert? Mr. Reichert, aye. Mr. Bustani? Mr. Bustani, aye. Mr. Roscom? Mr. Roscom, aye. Mr. Price? Mr. Price, aye. Mr. Buchanan? Mr. Buchanan, aye. Mr. Smith of Nebraska? Mr. Smith, aye. Ms. Jenkins? Ms. Jenkins, aye. Mr. Paulson? Mr. Paulson, aye. Mr. Marchant? Mr. Marchant, aye. Ms. Black? Ms. Black, aye. Mr. Reed? Mr. Reed, aye. Mr. Young? Mr. Young, aye. Mr. Kelly? Mr. Kelly, aye. Mr. Renacci? Mr. Renacci, aye. Mr. Meehan. Mr. Meehan, aye. Ms. Nome. Ms. Nome, aye. Mr. Holding. Mr. Holding, aye. Mr. Smith of Missouri. Mr. Smith, aye. Mr. Dold. Mr. Dold, aye. Mr. Levin. Mr. Levin, no. Mr. Rangel. Mr. Rangel, no. Mr. McDermott. Mr. McDermott, no. Mr. Lewis. Mr. Lewis, aye. Mr. Neal. Mr. Neal, aye. Mr. Becerra. Mr. Doggett. Mr. Doggett, no. Mr. Thompson. Mr. Thompson, aye. Mr. Larson. Mr. Larson, aye. Mr. Blumenauer. Mr. Kind. Mr. Kind, no. Mr. Pascrell. Mr. Pascrell, aye. Mr. Crowley. Mr. Crowley, no. Mr. Davis. Mr. Davis, aye. Ms. Sanchez. Ms. Sanchez? Ms. Sanchez, aye. Mr. Becerra? Mr. Blumenauer? Mr. Blumenauer, no. Chairman Ryan? Chairman Ryan, aye.
Oh. Madam Clerk, Mr. Becerra seeks to be recognized.
The gentleman's not recorded. Mr. Becerra, no.
Clerk will report the vote.
31 ayes, 8 noes.
There being 31 ayes and 8 noes, the motion is agreed to. 2 more bills in this category. I believe these are both bipartisan bills, so let's try and get through these bills before the first round of votes are coming up before the floor. Then we go into a grouping of bills on Medicare Advantage. So my suggestion is, provided the floor goes as we think it's going to go, let's get these 2 bills done, recess to vote, come back and do the Medicare Advantage bills. So the third order, H.R. 1190 is ordered favorably reported. Without objection, I also ask that staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. The third order of business is S-984, the Steve Gleason Act. I'll make a very brief opening statement, then recognize Mr. Levin. This bill would expand access to life-changing equipment called SGDs. SGDs are speech generation devices. People with severe diseases like ALS or Parkinson's disease need these devices to communicate with other people. They often add an SGD as an accessory to their wheelchair. Now, for a long time, Medicare has covered their wheelchair in these devices, and people have been able to buy SGDs so that they could customize their device. People have also been able to upgrade the devices at their own expense. For instance, many patients have installed something called eye gaze. If you have not seen this, you really need to do yourself a favor and look at this technology. It's absolutely incredible. I had a gentleman with ALS come to a town hall meeting I had in Dousman, Wisconsin recently to show me just how all he could really do was move his eyes, but because he could move his eyes through this device, he can answer the phone, he can talk, he can change the channel on the TV, he can change the thermostat. It's just incredible. It's a device that helps people who cannot move their arms or hands use SGD to communicate. So 2 years ago, CMS changed the policy. Seniors have to rent an SGD for over 13 months before they can buy it. What's more is Medicare will stop making the rental payments if seniors make upgrades that aren't directly related to speech. This change has been so sweeping that Medicare is refusing to pay for things like eye gaze, the very thing that patients need to use their SGD. So the bill would remove the 13-month rental requirement and allow seniors to buy their SGDs immediately. It also makes sure that Medicare continues to cover SGD if they are entering a nursing home, another problem that's experienced in this area. The people who need these devices are really, truly among the most vulnerable. The whole point of Medicare is to protect these very patients and give them the care they need and allow this technology to be acquired. So I think that this bill goes at the heart of Medicare's mission. I urge all of our colleagues to support it. Mr. Levin, you're recognized.
I support this bill, and I yield to Mr. Larson.
Mr. Larson is recognized.
I thank Mr. Levin, and I thank you, Mr. Chairman. I think I would also like to recognize and thank Representative Kathy McMorris Rogers for her strong advocacy of this bill. And as the Chairman indicated, the technology here, the innovation, but most importantly, the sensitivity. Anyone that's experienced, anyone who has ALS, and whether it's at a public forum or in person, to understand that we have this kind of technology and the ability to address this issue is paramount. Thank you, and I yield back.
Okay. Gentleman yields. The committee will now proceed to the consideration of S984. Without objection, the measure will be considered as read and open for amendment at any point. I'll now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a brief description of the bill, and I ask members hold their questions until after his presentation. Mr. Hoffman, you're recognized.
Chairman Ryan, Ranking Member Levin, S984 would provide Medicare coverage of speech-generating devices that are accessories to Medicare-covered power wheelchairs and are needed by severely disabled beneficiaries. The bill would establish that beneficiaries own their speech-generating devices upon receipt rather than at the end of a rental period. This upfront ownership change would be in effect for a 3-year period. The bill will also ensure that Medicare pays for speech-generating devices that use eye tracking technology.
Any questions? There being no questions, are there any amendments? There being no amendments, I will now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move the committee favorably report S984 to the House of Representatives.
The question is on favorably reporting S984. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it and the motion is agreed to. Motion is passed. Let me get to... The fourth order of business is S971. Wait, I apologize. Yeah, I keep doing that. S984 is ordered favorably reported. I'm always breezing through this. It's ordered favorably reported. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, and or minority views. The fourth order of business is S971, the Medicare Independence at Home Medical Practice Demonstration Improvement Act. Mr. Roscom, you are now recognized for an opening statement on this bill.
Thank you, Mr. Chairman. I'm pleased to see that S971, which is a 2-year extension of the Independence at Home Demonstration Project, which expired on May 31st, is included in today's consideration. This is a great idea, and it's a great idea in large part because it's been driven by a constituent of mine, Dr. Thomas Cornwell of Wheaton, Illinois. He's the president of the American Academy of Home Care Physicians and chairman and chief medical officer of the Home Centered Care Institute. He has a real passion for those he treats, and he's, check this out, made 30,000 house calls over his career. It's a remarkable thing, and to talk to him and to talk to the patients, there's a deep connection that they have and a commitment that he makes. And his work hasn't gone unnoticed. He's received a number of accolades. Now, we're here not to talk necessarily about Dr. Cornwell, but we're to talk about this program. And it's a demonstration that was created to test the effectiveness of delivering comprehensive primary care services at home to improve care for Medicare beneficiaries with multiple chronic conditions. Of the 34 chronic care demonstrations over the last 20 years, this most recent demonstration is decidedly different because it's targeted and fiscally responsible, because it requires a minimum annual savings of 5%. Think about the debate that we've been having over the past couple of hours. It requires good outcomes and patient and family caregiver satisfaction as a condition of participation. And it provides that additional incentives go to providers by allowing successful participants to share in any savings they generate for Medicare. Above that 5% mark, on an 80-20 basis. Medicare reduces costs where they're highest by focusing on the 5 to 25% of Medicare beneficiaries who account for as much as 80% of all Medicare costs. We can learn a lot from these demonstration projects. I urge its passage, and I yield back.
Mr. Levin, do you or designee wish to have an opening statement?
I support this bill and yield to Mr. Thompson.
Mr. Thompson recognized.
Thank the gentleman for yielding, and thank Mr. Roscom for working with me on this bill, or allowing me to work with him. This is a good bill, as was pointed out. We're talking about doctors making house calls to a small segment of our sickest Medicare beneficiaries. As was stated, it's fiscally responsible, it's targeted, it's focused on these folks, and it's had good results. And those good results mean people are better taken care of, and we save a little money along the way. I do want to point out two pioneers in this effort, California doctors, Dr. Bain and Dr. Vin, who have really led this effort nationally, doing great work, and we ought to make sure that they and the other folks who are participating in this program can continue. I urge an aye vote, and I yield back.
The committee will now concede to consideration of S. 971. Without objection, the measure will be considered as read and open for amendment at any point. We're going to do the walkthrough, then we can do. I'll now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a brief description of the bill. I ask members to hold their questions until he is finished with his presentation. Mr. Hoffman, you're recognized.
Chairman Ryan, Ranking Member Levin. S. 971 would provide a 2-year extension of an expiring Medicare demonstration program that provides intensive services in a beneficiary's home in an attempt to avoid care in more costly settings. The demonstration pays physician-led practices a bonus payment if they reduce the total cost of a participating beneficiary's care while maintaining quality. Extending the demonstration would allow the 15 participating practices to continue while giving CMS more time to publish the initial results.
Are there any questions for Mr. Hoffman? Yes. Dr. McDermott.
That's a fairly slim reporting of what these things are. What are they doing in them? I mean, the doctor just goes out to the patient's home, keeps them in the home. They never come to the office. Is that the basis of what it is?
No, the program is testing a service delivery and payment incentive model that uses home-based primary care teams designed to improve health outcomes and reduce expenditures for Medicare beneficiaries with multiple chronic conditions.
Because I was listening to the initial presentation. It said the doctor that thought this up made 30,000 home visits over a 20-year period. So I sort of divided that, and it seemed like an awful lot of home visits for a doctor to make to people. And does the doctor always go out to the house? Is that the idea, or is it just nurses and other people?
The participating practices include primary care practices and other multidisciplinary teams. They're led by physicians or nurse practitioners. They're organized for the purpose of providing physician services. They serve at least 200 eligible beneficiaries, so it covers a wide range of both in-home and outside services.
It's a demonstration for 200 people. Is that what we're hearing?
No. The eligible, the providers that are eligible to participate in the program have to serve at least 200.
Have to serve at least 200. Okay. Thank you.
Mr. Meehan, do you have questions?
I just a clarification. I think you have it. This opens the door. I mean, the value of nurse practitioners and others who are going into the home in a collaborative practice and therefore maintaining high levels of health care without putting the sick person back into the hospitals is one of the keys of this. So it does encourage the use not just of healthcare professionals, it could be rehab aides, other kinds of things as well, all under the collaborative practice. Is that not right?
Correct.
Okay, that's my question. Thank you.
Any other questions? If no further questions, are there any amendments? Ms. Sanchez, I believe you.
I do. Thank you, Mr. Chairman.
Gentlelady, we'll suspend until the clerk distributes the amendment.
Mr. Chairman.
Mr. Brady.
I reserve a point of order.
Point of order has been reserved. Don't worry about it.
Yeah, go figure.
Okay. The gentlelady from California is recognized.
Thank you, Mr. Chairman, and thank you for an opportunity to raise an amendment to S 971. I'd like to take this opportunity to quickly bring attention to legislation that is similar to S 971, and that Representative Meehan and I have been working on to deliver community-based services to keep individuals healthy without reducing their meager assets. Some beneficiaries require long-term care traditionally provided by Medicaid, but limited financial means makes them ineligible for such services. Unfortunately, there's nothing in current law that would prevent them from racing into poverty to receive those services. Our bill would establish a new community-based institutional special needs plan demonstration program to help our seniors avoid the dreaded Medicare spend down while allowing them to receive long-term supports and services in their homes without the need of being institutionalized. The mechanics of the bill are rather complicated, and we're working through all of the intricacies in the hope of having a strong bill to mark up the next time that the full Ways and Means Committee meets to mark up healthcare legislation. Mr. Meehan and I remain committed to working on this and look forward to working with the committee staff to make this a reality. And just finally, I wanted to highlight the great help of committee staffers Nick Ulecki and Melanie Egerin for their work on our bill. Throughout countless changes, they've worked tirelessly to help us with the legislation, and I just wanted to personally thank those two for their work. With that, I will yield back the balance of my time and give you back those 3 minutes that you gave.
Hey, all right. Does the gentlelady withdraw her amendment?
I will withdraw my amendment.
The amendment is withdrawn without objection. Are there any members who seek to strike the last word or to amend? Yep.
If I may, in addition to withdrawing the reservation of point of order, would like to say this does have real merit. There is bipartisan support on this, and we are committed to working with Ms. Sanchez and Mr. Meehan on moving this forward.
Thank you. Any other? Mr. Davis, the gentleman's recognized.
Thank you, Mr. Chairman. I move to strike the last word.
Gentleman's recognized.
Mr. Chairman, I have long been a real fan of all types of home visitation where individuals can, in fact, receive care. And I commend those practitioners who are willing to go into people's homes to provide services to them. I commend Mr. Roscom for his introduction of this legislation. I also agree with Ms. Sanchez and her effort to perhaps expand it. And the gentleman mentioned by Mr. Roscom is indeed a legend in our communities, and I simply want to extend to him the commendation for the outstanding services that he has provided over a number of years and promoting this concept that you can provide care to individuals in their homes. I support this very strongly and yield back.
Gentleman yields back. Are there any other members who seek to strike the last word or offer an amendment? There being none, I will now recognize Mr. Johnson for the purposes of offering a motion.
Thank you, Mr. Chairman. I move that the committee favorably report S 971 to the House of Representatives.
The question is on favorably reporting S 971. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. S 971 is ordered favorably reported. Without objection, I ask that staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Without objection, the committee now, looks like they're about to go to a vote here. I think any second now, so why don't we adjourn and go to the floor? People can grab a bite to eat, and then come back and finish the markup. So without objection, the committee stands in recess subject to the call of the chair, and we will resume immediately after the next series of votes.
What's up first?
2580. Ready? The committee will come back to order. The committee will come back to order. Let me try this again. Testing. No? Testing? Try yours.
Hello. Hello.
Hello? You gotta be kidding me.
We need to move to another room.
Yeah. What is...
Hello?
No, I don't... Testing? No. That's not a mute. Override. What's that? I know, but Sandy's isn't working either.
Yes, yours works.
Testing?
Works down here,
No.
doesn't it? Yeah.
Hello?
Yeah.
Testing? That one's working.
It worked down here? Yeah, Chairman.
Yeah, testing.
Oh.
That's really strange. We just got a new system. The committee will come to order. The next order of business is H.R. 2580 to provide for a technical change to the Medicare long-term care hospital moratorium exception. Mr. Bustani, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. I appreciate the committee's willingness to consider this legislation to address an inconsistency in previous long-term care hospital policy that proved highly impactful to long-term care hospitals and facilities in my district, as well as many across the country. I've been a long-time proponent of competition in the healthcare marketplace, believing that competitive markets have the ultimate and simultaneous effect of cost reduction and quality improvement that has become so critical in the present healthcare environment. This legislation is pretty simple. It revises the most recent update to the long-term care hospital Medicare coverage policy in 2014 to reflect the original LTAC expansion exceptions process. More specifically, the legislation ensures that facilities meeting certain criteria be afforded consideration for Medicare coverage of additional facility beds, which directly enhances patient access to these highly intensive and critical healthcare services. And for that reason, I urge passage of the bill. I yield back.
Mr. Levin, you're recognized. Yeah, it is working.
Hello. Let me just comment briefly on this. I don't think any of my colleagues on the Democratic side at this point necessarily want to participate. I think the purpose of it is understandable. Now it's working. But let me, maybe a bit out of order, let me ask Mr. Hoffman, because it will relate to my comments. How, in determining the cost estimate, about how many long-term care hospitals do we expect would be affected by this?
It's unclear at this point. The exemption process would be eligible to all LTACs that chose to apply for it. Those who are mid-billed would obviously apply first, but it would be open to everybody. We don't have an estimate back from CMS.
There is a cost estimate on this, though, right?
Yeah, we anticipate from preliminary score from CBO that this would cost about $50 million over the 10-year window.
So they must have had some idea as to how many hospitals might be affected, right?
We've asked for that level of detail, but we haven't received information yet on that.
I think, Mr. Chairman, we should have this before this would go to the floor, because it's somewhat unusual to have a scoring, but without any idea as to how many hospitals would be affected. And I also mention this because this is paid for, correct?
Yes, sir.
So I think this is the first bill that's coming before us that's paid for. And as I think we know, the American Hospital Association has sent us a letter protesting or criticizing, however you want to define it, how this is paid.
Mr. Levin, is this your opening statement, or do you want to?
It really is.
Okay, all right.
It is.
All right. 235.
Because they're kind of protesting because the cost of this is spread among all the other facilities, right?
Correct.
And so I think it may be a good idea, but I really think to be sure it's a good idea, we really need to know about how many different facilities might be affected by this, and therefore whether it's fair to spread the cost among all of them. That's really my opening statement. As you can see, it's a bit uncertain because the universe here is so undecided. And so, again, I would urge, do you have any idea when that kind of a cost estimate will be coming?
We have requests out to both the Congressional Budget Office and CMS to get that kind of information. As soon as we have it, we'll provide it.
And they think this will come fairly soon?
That's our hope.
Okay, I close with this also, Mr. Chairman. I think you and I and everybody else here really wants to understand a universe before we act on a bill to make sure that it isn't so small a universe that it might raise some questions. And I'm not doing that now, Mr. Bastani, at all. I just think we need to have that information. And that's also, I think, being fair to a distinguished organization, the American Hospital Association, that doesn't really support spreading this to additional payment cuts, in essence, to other facilities. So with that, I yield back the balance of my time.
Gentleman yields back the balance of his time. The committee will now proceed to consideration of H.R. 2580. I offer an amendment in the nature of a substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and considered base text for purpose of amendment. I will now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a brief description of the bill, and I ask that members hold their questions until after his presentation. Mr. Hoffman.
H.R. 2580 has two components. First, it makes a technical change to the Medicare long-term care hospital moratorium exemption. It would allow long-term care hospitals, or LTACs, that had plans in place to extend their number of beds to exercise the current law exemption process to the bed moratorium. The start date for the new exception reverts back to the date of the previous LTAC technical correction on new building expansion established in the Protecting Access to Medicare Act that was signed into law on April 1st, 2014. The second component would modify Medicare outlier payment methodology for LTACs to offset the increased spending that would occur as a result of the previously described technical change. The modification to the outlier payment methodology will not apply to the site-neutral discharges established under current law. The amendment in the nature of a substitute makes several modifications to the underlying bill to facilitate CMS administration of both the exemption to the moratorium and the modification to the outlier pool payments.
Are there any questions for Mr. Hoffman? Dr. McDermott.
Mr. Chairman, as you know, we have a suit before the Supreme Court about some words that weren't quite right about subsidies and who, as a state or whatever. It sounds to me like what you're describing here is a mistake that was made in the drafting in 2014 in which they excluded existing hospitals from asking for the use of the exemption, whereas they gave it to new hospitals, and they should have given it all. Is that the essence of this?
This is a technical correction bill that amends the moratorium process.
But that doesn't really respond to my question. The bill or the law as it exists says that if you are an existing hospital, you cannot apply for an exemption to expand your facility. But if you're a group coming from out of nowhere and want to start a new one, you can ask for an exemption. Is that correct?
This applies only to expansion of beds, so it's not would be for this isn't relevant to the moratorium on expansion. This is the expansion just for the number of beds.
So you can't build a new hospital is basically what you're saying.
Right, that was already corrected in a previous technical correction bill. This one just speaks to the number of beds.
But this says that if you're an existing hospital, you can expand like you can from some other source, huh?
Correct.
All right? And then it's paid for by taking the money from the existing long-term hospitals and giving it to the, this is a budget neutral provision, if I understand it correctly.
Correct. The offset comes not from payments, but from an outlier pool. CMS maintains an annual pool of payments to reimburse LTACs for outlier charges. These are abnormally high cost or complex cases. The standard federal LTAC payment rate is reduced on an annual basis to fund this pool. CMS has historically set the pool at 8%. The offset to this bill simply reduces that 8% by an amount to offset the increased spending that would occur by expanding the moratorium process.
I really don't know how to ask the question of you, but why is the American Hospital Association not in support of this? I mean, what is it about the provision that they don't
That's
like?
not an appropriate question for the staff director. He can't answer that question.
Okay, I'll ask you, Mr. Chairman, in a minute.
Yeah.
Thank you.
Anybody else see questions of Mr. Hoffman? Okay, if there are no more questions, are there any amendments? There are no amendments. Does anyone seek to strike the last word? Mr. McDermott.
Mr. Chairman, this, as I read this piece of legislation, it reminds me of a doctor from the University of Washington who took a safari to Africa, and they were in one of the game preserves in Botswana, and you were told by the guides, never put your hands in the water. Don't drag your hands to cool off in the water, because there are all kinds of things in the water, and you might wind up being sorry. He hung his hand over the side of the boat, and an alligator got a hold of him and pulled him down into the water, and he was never seen again. And I feel like this is sort of that kind of an amendment. There's alligators in these waters here, and I'm not sure who the alligators are or what they're up to. And that's why I asked the question.
Why are they opposed?
Tell me why the American Hospital Association doesn't like this bill.
Let me ask Mr. Bustani, Dr. Bustani, to get into this.
Yes.
Dr. Bustani, do you mind moving to strike the last word and giving some clarity on this issue?
I'll move to strike last word.
Gentleman's recognized.
We've got a very competitive healthcare environment where you have hospitals that do complete services. Some of them have LTACs, and obviously some don't. You have situations where you have freestanding LTAC hospitals that serve a very important purpose. And I suppose this is caught up in the politics of that. I don't know all the details because I haven't heard directly from the American Hospital Association about this. But this is just a technical change. It's a technical change that deals with additional beds that will fill a need.
So this would be, if I understand, then you're saying, if you yield to me.
Yes, I'll yield to you.
This is just a consent bill, and it doesn't really make any difference which way you vote on it, because nobody seems to, nobody's going to get hurt. It's a neutral bill in terms of money.
It's a neutral bill in terms of money. It's the impact. It's not going to affect a whole lot of patients in the long run. I mean, the pool is from the outlier pool, which is we have that's 8%. I think this is going to affect less than 1%, if I'm correct in the calculation. Is that right, Mr. Hoffman?
We estimate it'll be a small number, but we want to be sure before we provide a direct answer.
Right.
Yes, Mr. Chairman, I yield my time to you.
Well, Dr. Bustani, will you yield?
I'll yield back, yes.
So, you know, the way I interpret this letter, which quite honestly I'm a little puzzled by, is they want some relief from the moratorium because it incorrectly prevented expansions from occurring that were in the works.
That's right.
And so what we're saying here is, well, we should have it paid for from the same community that is asking for the relief. That seems to kind of make sense. Now, is it going to be dollar for dollar, hospital by hospital? know, but this is as close as it gets. What I get from this letter is, please provide the relief, but take the money from somewhere else, not from the community in which we're providing the relief. And, you know, for the life of me, I don't really understand the thinking of that.
Well, Mr. Chairman, could I?
Yeah.
Could you yield?
It's Dr. Bustani's time.
I'll yield.
Does that seem to you like the...
An alligator issue?
No, the medical device tax?
Those, we passed those bills already. Let's stick to the topic at hand.
It seems
we
to
can
me...
go on and on and on, but I don't even know who's controlling time anymore. It's Dr. Bustani.
Still my
Dr. Bustani,
time,
will you yield back the balance of your time?
I will yield back the balance of my time.
Mr. Levin, do you move to strike the last word?
I do.
Gentleman's recognized.
So the letter just arrived today or yesterday, so it's not surprising that we all haven't seen it. So I'll read this. So it says, this bill establishes a technical correction to the current LTCH moratorium to allow certain moratorium exceptions for existing LTCH. The bill would be offset with a reduction in the LTCH outlier payments. Given the numerous payment reductions LTCHs are preparing to face this year, we strongly encourage the committee not to seek money from the LTCH prospective payment system to pay for this legislation. Specifically, the Budget Act of 2013 established stringent LTCH payment criteria, which will reduce reimbursements for one of two current LTCH patients, resulting in a $3 billion cut in LTCH payments. Further, the Medicare Access and Chip Reauthorization Act reduces the final year 2018 LTCH market basket to 1%. Due to the magnitude of these cuts, now is not the time for congressional action to further reduce LTCH payments. Rather, it's now the time for LTCH field and policymakers to focus on implementing this congressional mandate for the new complex LTCH criteria. So I raised the issue earlier in the questions to you, Mr. Huffman, because I think what we need to do right after we pass this, which we will, to really look at the scoring here, try to figure out what the impact will be on how many different long-term care facilities, and then decide whether this is good policy. I think this isn't just a self-serving proposal, it's or reaction. It's somewhat deeper than that.
Okay.
So I yield back. I think we should pass this with our understanding, with the integrity of this committee in mind that we all share, that we should have further information before we bring it to the floor.
Gentleman makes a valid point. Gentleman yields back balance of his time. Mr. Brady, you move to strike the last word?
Yes, Mr. Chairman.
Gentleman's recognized.
Be very brief. You know, the underlying policy of this bill is not opposed by the Hospital Association. There are concerns with the pay for. But let's look at the context. We all, I believe, support site-neutral payments, where Medicare makes the appropriate payment for the appropriate treatment in the appropriate setting. In 2013, the LTAC community worked closely with this committee, Republicans and Democrats, to establish site-neutral payments that created savings for Medicare, requires changes by the industry. But in that was included a moratorium based on certain criteria. Mr. Bustani's bill is the third exception, all of them relatively minor. I'm not a fan of more exceptions to a moratorium, and I'm hopeful this sort of draws this to a close. But the point is that CMS has an outlier pool to deal with complex patients from which they draw these payments. It is just as they do with acute care hospitals, which has a 6% outlier pool to do exactly the same thing. Hence, the Hospital Association is very familiar with this process. The outlier pool for LTACs is high, 8%. I predict that at some point CMS, because this is not in statute, will lower it itself. And so by taking this action, which I think will probably impact, a fairly small number of beds and will probably have a fairly small impact overall, it does go to the issue we've just heard about for 2 hours or so, which is let's find ways to pay for these policy changes within that industry, and let's ensure it's done by legislators, not by CMS or others who frankly don't have, in my view, jurisdiction should be left with us. And so I think this is a reasonable bill, I think with a reasonable pay for. I like the idea of getting more information going forward, and I agree with the Ranking Member Levin that this is a bill worth passing. Yield back.
Anybody else seek to strike the last word? Hearing none. If there are no more questions, the question is on the adoption of the amendment in the nature of substitute. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of substitute is agreed to. I now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2580 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2580 as amended. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it. The motion is agreed to. H.R. 2580 is ordered favorably reported as amended. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Next order of business is H.R. 2505, the Medicare Advantage Coverage Transparency Act. Mr. Kelly, you are now recognized for an opening statement on your bill.
Thank you, Chairman, and thank you for bringing the bill up for a vote. Also want to thank Congressman Kind and also Congressman Bilirakis. They were all together on this. H.R. 2505, the Medicare Advantage Coverage Transparency Act, is just that. It's a bill to make more transparent Medicare Advantage coverage for our seniors. With the passage of H.R. 2505, CMS will be required to provide additional information on Medicare Advantage enrollment based on zip code, congressional district, and state. This data will be available for both Medicare Advantage prescription drug plans as well as regular Medicare Advantage plans, and enrollment data under Part A, Part B, enrollment under Medicare Advantage under Part C, and enrollment under Part D will also be covered. Now, the purpose of this additional data is to provide greater information to the public, to policymakers, and the healthcare community, so they may have the benefit of more and better information when making these decisions. In 2014, the majority of the 54 million people on Medicare are in the traditional Medicare program, with 30% enrolled in Medicare Advantage plans. Since 2004, the number of beneficiaries enrolled in private plans has tripled from 5.3 million to 15.7 million in 2014. In my home state of Pennsylvania, 18% of the total population in the Commonwealth is enrolled in some form of Medicare. Of that 18%, 39% of Medicare beneficiaries are enrolled in Medicare Advantage plans. That means that about 7% of Pennsylvanians are enrolled in a Medicare Advantage plan. Now, this legislation will give all of us, including me, the ability to know more information about how changes in Medicare Advantage plans in Washington will impact our districts and our constituents back home. And I want to thank the chairman for bringing this up and look forward to this getting passed. Thank you.
Mr. Levin, you were recognized for an opening statement on the bill.
I happily yield to Mr. Kind.
Mr. Kind's recognized.
Thank you, Mr. Chairman. Mr. Chairman, I don't have really much to add from what my friend and colleague, Mr. Kelly's already described the bill as. It's a simple transparency bill. I think more data is important and it'll be helpful. It'll help guide us policymakers, but also the MA plans themselves. And enjoyed working with Mr. Bilirakis on this legislation. I encourage our colleagues to support it. I yield back.
The committee will now proceed to consideration of H.R. 2505. I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and consider base text for purpose of amendment. I'll now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a brief description of the bill, and I ask that members hold their questions until after his presentation. Mr. Hoffman.
Chairman Ryan, Ranking Member Levin. H.R. 2505 would require CMS to report Medicare Advantage enrollment data by zip code, by congressional district and by state to the congressional committees of jurisdiction by May 1st of each year and no later than June 1st of each year. The amendment in the nature of a substitute would require that CMS also report this enrollment data across all parts of the Medicare program.
Any questions of Mr. Hoffman? Pretty straight. Mr. Doggett.
Thank you very much. Mr. Hoffman, how long have Medicare Advantage plans been in existence?
Medicare Advantage plans under their current formulation were created in the 2003 MMA bill.
Well, in some forms, don't they go back even decades before that? Aren't we talking about roughly 30 years of some type of medication?
Mr. Hoffman, pull your mic a little closer. We can't hear you as well.
They were originally known as Medicare Plus Choice plans.
Yes. And as originally presented and as reconfigured at the time you mentioned, all of them were originally presented to Congress as something that would save money on Medicare, weren't they?
I would have to go back and check the record for that.
Can you advise us how much money Medicare Advantage has saved versus traditional Medicare?
Mr.
Year,
Doggett, this is, the question doesn't bear relevance to the bill.
Well, I just heard Mr. Kelly say that the benefit of this bill was more and better information, and that's what I'm trying to get. These plans were, and I suppose you say they're open to amendment, that getting more and better information would be appropriate about all aspects of this plan. They were presented to Congress as a way of saving money for Medicare, and I'm trying to determine how much savings or cost we've had.
The bill is a limited bill, a bipartisan limited bill, designed to get members of the committee more information on Medicare Advantage itself. It is not a bill dealing with scores or savings such as the questions you're asking.
All right, so you would not be open to amendment to report, I'm all for the information you're getting a report on, but reporting on what the cost of Medicare Advantage.
I'm not discussing what we're open to or not. I'm just saying you're asking a question beyond the scope of the bill of the staff director. That's all.
Well, he is the staff director of the Health Committee. Surely he's familiar with whether these plans that you want to provide us more information about are costing money or saving money.
I think that's a question for CBO.
Well, it may be a question for the author, but if you prefer that I do it when I strike the last word, I will do that.
Let's do that.
Okay.
Let's do that. Any other questions?
Mr. Chairman.
Dr. McDermott.
So when this bill passes, at the next Congress, I will have the number of people in my district who have Medicare Advantage and those who are in the regular Medicare program.
Correct.
And that's the only information we'll collect. We're not going to collect. You said you're doing it by zip code, so I assume that I'll know that 98-114 or 98-119, or I will know how many in that district have these programs, the two programs.
That's the intent of the legislation.
So it's going to give me two baskets, one who are taking Medicare Advantage and one who are using the usual fee-for-service Medicare program.
Right. This is across all parts of the Medicare program. So A, B, D, A and B, and Medicare Advantage.
It was originally written. I mean, I understand we got an amendment here, but the original bill was only for Medicare Advantage. That's as I understand it.
Correct. The amendment in the nature of a substitute adds that CMS provide the additional data, enrollment data, across all parts of the Medicare program.
Thank you.
Any further questions? Are there any amendments? No amendments? Do any members wish to seek recognition to strike the last word?
I do.
Mr. Doggett.
These Medicare Advantage plans I support getting this additional information, but the whole concept originally was presented as a way of saving taxpayers' money. And that's why I've sought to inquire about exactly how much money's been saved. I think, in fact, we go back to the time the Affordable Care Act was adopted, that it was, instead of saving money, it was costing us about $1,100 per beneficiary more. That is to say that those people on Medicare Advantage were getting about $1,100 more per person than those that were in traditional Medicare. The traditional Medicare seemed to have a more efficient administrative cost structure as well. There have been some changes since then. I think the disparity and the added cost percentage-wise has been reduced. This and a number of the bills are designed to I think, encourage Medicare Advantage. And as we encourage it, I think we need a better understanding of the cost structure and how much more taxpayers are being asked to pay. And that's why I was inquiring about this issue. I know you, Mr. Chairman, you have a number of ideas about programs similar to this in other aspects of our system, and I just think it's useful to get the data.
Will the gentleman yield?
Yes, sir.
I concur with that. My point is that the proper place to make such an inquiry would be either CMS or CBO, the keeper of the numbers. If memory serves, when we had that debate at that time, on an apples-to-apples basis, which really isn't apples-to-apples, fee-for-service against MA plans, in some cases MA plans did, quote-unquote, cost more, but if you recall, that money went into the form of lower copays or better benefits for the beneficiary. We can judge whether we should be doing that or not. And also, some MA plans came in below cost. So it's a mixed bag, and it's really an apples to orange comparison. I think the purpose of this bill is to get a better and more granular look at market penetration and more information so that we can really truly discern whether or not it actually is a more cost-saving plan. And the other ideas that we have are all intended at getting just that, trying to get our dollars worth, trying to get more bang for our buck by giving patients more choices and injecting more competition into the Medicare provider system.
Well, I thank you for those additional comments. I think that certainly there is good reason to look to see whether there are ways to strengthen Medicare for all. And you're right, some people out of that, what was estimated at about $1,100 extra per person, got some additional benefit from that others within Medicare do not receive. And I will make inquiry of the two sources that you mentioned. And I believe MedPAC also has had some information on this matter. But those who have thought that Medicare Advantage or Medicare Choice was a panacea for our seniors, it has to date been a costly panacea, and I think we have invested billions of additional taxpayer dollars instead of seeing taxpayer savings as a result of these plans. They may have merit even at that, and certainly there's merit in getting more and better information, but one of the critical issues is what does it cost us for these plans, and did those who advanced them fulfill their pledge of reducing cost and saving taxpayers money in order to deliver at least the same quality of health care.
Point taken, and if the gentleman will yield just for a few seconds further, and we should also make sure we can do it as much of an apples-to-apples comparison as possible so that we stack up your Medigap plan with your Part D plan with your A and B compared to a Medicare Advantage plan so that we can get a real equivalent measurement.
I look forward to working with you on that.
Great.
Thank you.
Thank you.
I yield back.
Gentleman yields back. Anybody else? Dr. McDermott?
Mr. Chairman, the reason I raised the question I did, and I want to make it clear, if you look at all these medical advantage bills in front of us today, it reminds me of how you boil a frog. You never get the water boiling and put him in because he'll jump out. What you do is you put the frog in cold water and you gradually heat the water up. This bill will now give the industry the ability to come to every member of Congress and say, you've got so many members in Medicare Advantage and you've got so many in fee-for-service, and the pressures will begin. It's a good place. I admire your strategy. But the thing that's troublesome, and Mr. Doggett alludes to it, in today's Modern Healthcare, which is a magazine that anybody in the field reads, on today, or yesterday, June 1st, came out with a article, Upcoding in Medicare Advantage may cost the government $5 billion a year. The government is paying an extra $5 billion a year to Medicare Advantage plans because of upcoding, according to a new working paper at the National Bureau of Economic Research. And they go on to lay out how this happens. If you're a Medicare plan, a Medicare Advantage plan, you say to the government, well, this person is not very sick, and so we get a little bit of money. But if they get them, if they can make them, upcode them to a more sick patient, they get more money. And the tendency to upcode is very obvious to any researcher who looks at it. And that's where the additional money always comes to Medicare Advantage, because they appear to be taking care of sicker people who are in fact not sick or less sick. They're sick, but they're less sick. And in the fee-for-service, you just pay whatever the doctor says, and you don't do that. You don't upcode to get more money out of the system. If you do that, you wind up being an outlier in the payment plan, and then people look at your records to see, why are all your patients the sickest in the world? So this issue of cost control is going to be our real problem in the future. Those of us who like Advantage, ACA, worry that the costs will get out of control, and then people will say, you see, we shouldn't do it, we should throw it out, and maybe toward the end of this month we'll find out what that amounts to. If the Supreme Court decides in the right direction, we may see what the alternative to an Affordable Care Act is. But you cannot say, or we should be looking not only at who has Medicare Advantage, but how do they get into it? And I'll talk further about some of these bills down the way, because they change the sort of culture of Medicare Advantage. And I personally intend to vote against this. I don't need to know how many in my district have which or the other. There's no advantage to that. It doesn't cost anything very much, but we'll see down the road what it's worth.
Gentleman yields back. Anybody else seek to move to strike the last word? If there are no other questions, question is on adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. And those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2505 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2505 as amended. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 2505 is ordered favorably reported as amended. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. The next order of business is H.R. 2506, the Seniors Healthcare Plan Protection Act. Mr. Buchanan, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. Medicare Advantage plans have a proven track record of improving health outcomes, reducing costs, and offering much-needed personal choices to seniors. I'm fully committed to strengthening and preserving this vitally important program any way I can. In speaking with seniors in my districts and healthcare providers throughout my district, it is clear that there is ample room for improvement in Medicare STARS rating system. While we work to improve this flawed rating system, my bill ensures that seniors in programs, they can continue to receive the care from the doctors of their choice. This bill will ensure that seniors across the country, including 10,000 seniors in my congressional district, are able to keep the care and benefits they choose because the plan fits their needs. I urge my colleagues to pass this bipartisan Senior Health Care Plan Protection Act. I also want to thank Mr. Rangel for his support and leadership in this bill, and I yield back.
Mr. Levin, you are recognized for an opening statement on the bill.
You to Mr. Rangel.
Thank you, Mr. Levin. Thank you, Mr. Chairman. I really enjoyed working with Mr. Buchanan on this. As we had said earlier, we had expected to get a lot of savings out of restrictions on Medicare Advantage, but under the so-called STAR system, we had found that many of the poor and the aged and the sick have found it difficult to score high enough in order to threaten their existence. CMS has delayed determination. This will give us, with Mr. Buchanan's leadership, a 3-year opportunity to see what we can do in order to make it fair and equitable to the people receiving this health care now. In addition to that, this will bring additional relief to our citizens in Puerto Rico. The majority of them have been on the Medicare Advantage, and because of the poverty that exists on that island, a lot of them would be vulnerable to losing hundreds of millions of dollars because they involved with Medicare Advantage, and special programs have had to be found in order to allow them to get adequate health care. And so for all of those reasons, Mr. Chairman, I'm glad to join in with Mr. Buchanan and others to give CMS an opportunity to bring some equity to the delivery of health services. I yield back.
Thank you. Gentleman yields back. The committee will now proceed to consideration of H.R. 2506. I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any time and considered base text for purpose of amendment. I now turn to Matt Hoffman, the staff director of the Health Subcommittee, to provide a brief description of the bill, and I ask that members hold their questions until after his presentation. Mr. Hoffman.
Chairman Ryan, Ranking Member Levin. H.R. 2506 would delay for 3 years CMS's authority to terminate Medicare Advantage contracts for plans that have received 3 stars or less for 3 consecutive years under the STARS rating system. This delay would not prevent CMS from terminating plans for the other categories considered in the past cycle performance review at any time. The amendment in the nature of a substitute makes a technical change to the finding section of the bill.
Are there any questions for Mr. Hoffman? Are there any amendments? Anybody wish to strike the last word? If there are no questions or no motions to strike the last word, the question is on adoption of the amendment in the nature of substitute. All those in favor signify by saying aye.
Aye.
Those opposed, no. In the opinion of the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2506 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2506 as amended. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 2506 is ordered favorably reported as amended. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. The next order of business, H.R. 2507, the Increasing Regulatory Fairness Act. Mr. Brady, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman. This is an important, simple, but bipartisan piece of legislation that I share with Mr. Thompson of California and Mr. Pitts, Chairman of the Health Subcommittee of Energy and Commerce. Today, Medicare Advantage program serves more than 16 million seniors across the country. Enrollment has increased more than 3-fold in the past decade and is expected to nearly double in the next. To ensure that seniors are able to continue receiving the high-quality care they receive under this program, the Centers for Medicare and Medicaid Services is expected to pay about $156 billion to more than 3,600 Medicare Advantage plans just this year. That's nearly 30% of all that Medicare spending, by the way. Typically, every year, CMS sends out what is called a rate notice to plans and Medicare Advantage companies that detail the various payment rates and benefit changes for the agency plans to make for the following plan year. This notice follows the standard rulemaking process of other payment systems. That is, a draft notice is published, the public has a certain amount of time to submit comments and questions, and then the agency publishes a final notice based on the feedback. Right now, this current process takes about 45 days. Do you know how many days are currently allotted for the commenting portion? Just 15 days. 15 days for thousands of plans and millions of stakeholders to submit comments on proposed changes to a program that amounts to 1/3 of all Medicare spending. I can almost understand this if the rate notices were a short and concise document, easy to understand and simple to implement, but they are not. The rate notice has grown from around 16 pages to nearly 150 pages this year. That's a 9-fold increase. All the while, the time for the public comment period has remained the same. This means less and less time for plans and Congress to conduct the necessary review so they can provide CMS the kind of feedback that would better help the agency assess the impact of their proposed changes. This is important because without accurate feedback, CMS could inadvertently move forward with a proposed change to the Medicare Advantage program that might negatively impact these seniors who depend on these plans for access to essential medical care. Legislation before us is simple, straightforward. All it proposes is to extend the public notice period from 45 to 60 days, which would mean an extension of the comment period from 15 to 30 days. This is just a common sense, good government fix we can make. It'll give plans more time to understand the changes CMS proposes, offer constructive feedback, make the Medicare Advantage program overall more responsive to seniors' needs. Again, I want to thank Mr. Thompson, Mr. Pitts for their thoughtful and helpful work on this legislation. And Mr. Chairman, with that, I yield back.
Mr. Levin is recognized.
I yield to Mr. Thompson.
Thank the gentleman for yielding. I enjoyed working with Mr. Brady on this piece of legislation. I think he covered all the points. It increases transparency, gives all the stakeholders and our staff and us time to review this material. As he pointed out, it's in the last 10 years, if these things have grown from 20 pages to over 100 pages. You don't have time to review them and understand them. This is a much needed piece of legislation that will produce a better system for people we reserve. I agree with everything you said. Good authors, good policy. I ask for an aye vote.
The committee will now proceed to consideration of H.R. 2507. I offer an amendment in the nature of a substitute, which was distributed in advance, along with a green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and considered base text for the purpose of the amendment. I'll now turn to Matt Hoffman, the staff director of the Health Subcommittee, to provide a description of the bill. Hold off on your questions until after his presentation, please.
Chairman
Mr.
Ryan,
Hoffman.
Chairman Mine, Ranking Member Levin. H.R. 2507 would extend the annual regulatory public notice schedule for Medicare Advantage payment rates from 45 days to 60 days. This would also extend the public stakeholders' comment period. The amendment in the nature of a substitute would make a technical change to ensure the extended comment period applies to both the call letter and rate notice.
Are there any questions of Mr. Hoffman? Any amendments? Any motions to strike the last word? Seeing none, the question is on adoption of the amendment in the nature of a substitute as amended. All those in favor signify by saying aye.
Aye.
Those opposed, no. In the opinion of the chair, the ayes have it. The amendment in the nature of a substitute is agreed to. I now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2507 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2507 as amended. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 2507 is ordered favorably reported as amended. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill and that members have 2 additional days to file with the committee clerk supplemental additional dissenting or minority views. 2 more, right? Yep. The next order of business is H.R. 2579, the Securing Care for Seniors Act of 2015. Mrs. Black, you are now recognized for an opening statement on your bill.
Thank you, Mr. Chairman, and I thank you for your consideration of H.R. 2579, the Securing Care for Seniors Act of 2015. The Medicare Advantage program plays an important role in providing coverage for over 16 million seniors, including coordinating care for at least 3 million dually eligible individuals and many other low-income seniors who often suffer from serious chronic conditions. These individuals should have access to coverage specifically tailored to their needs and dedicated to their unique health and well-being. We must ensure that incentives are appropriately aligned to achieve this result. Each Medicare Advantage plan enrolls a distinctive mix of beneficiaries with different demographics and varying health care needs. These factors can lead to radically different health care costs for different patients. Risk adjustment is intended to account for these differences by adjusting payment based on predicted beneficiary costs but the model has been flawed in the past. Now, to correct for inaccuracies in the past, the CMS has changed the model, but has done so with very little transparency and input from Congress or the stakeholders. Many of the changes recently instituted by CMS leave some of the Americans' most vulnerable citizens at risk by discouraging plans to detect and care for chronic conditions in their early stages. Further, a growing body of evidence indicates that the method CMS uses to rate these plans on quality is extremely flawed and does not account for the special needs of the lower-income seniors. This bipartisan legislation requires CMS to study the impact of the recent policy changes and to correct course if it proves to be harming to those Medicare beneficiaries. It also provides for a more transparent process with the opportunity for the stakeholder feedback when making policy changes to the program. I'm committed to working with the stakeholders, CMS, and my fellow colleagues on this committee to offer solutions that protect access to plans for our nation's seniors. I want to specifically thank Mr. Blumenauer for being such a wonderful partner on this and other Medicare Advantage bills. And thank you, Mr. Chairman. I yield back the balance of my time.
Gentlelady yields back the balance of her time. Mr. Levin, you're recognized for an opening statement on the bill.
I yield to that wonderful partner, Mr. Blumenauer.
Gentleman is recognized.
Thank you. Thank you, Mr. Levin. Ms. Black, it's been a pleasure to work with you moving this forward, and I think you outlined the need for this legislation, and why I hope everybody feels comfortable uniting behind its support. We have, as referenced, 16 million people who are taking advantage of Medicare Advantage. I come from a community where there was early adoption, heavy penetration, and characterized by plans with very high outcomes. That's not always the case around the country. And as Ms. Black pointed out, we want to make sure that we're not having a disadvantage for folks that are diving in to try and take full advantage of harnessing the ability to deal in a more holistic fashion with folks. It is appropriate for us to weigh in into what the evaluation is, to give guidance and direction, and to encourage, to make sure that we are doing everything we can to encourage the high-quality plans to deliver high-quality, coordinated care to some of our most difficult and vulnerable seniors. I look forward to moving this forward. Appreciate the opportunity to partner with you, Ms. Black, and hope that the committee acts in the affirmative.
Gentleman yields back the balance of his time. The committee will now proceed to consideration of H.R. 2579. I offer an amendment in the nature of a substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and considered base text for the purpose of amendment. I now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a description of the bill. Please hold off on your questions until after his presentation. Mr. Hoffman.
Chairman Ryan, Ranking Member Levin, H.R. 2579 would require CMS to evaluate and, if appropriate, incorporate minor changes to the Medicare Advantage risk adjustment model. Specifically, the legislation asks CMS to consider multiple years of data and the impact of multiple chronic conditions when calculating risk adjustment. If the review of these changes is found to have made risk adjustment less accurate, the legislation asks the Secretary to make the necessary revisions. The legislation also includes a sense of Congress regarding the Medicare Advantage STARS rating system, citing work that the Congress plans to do in reforming the system in conjunction with CMS and stakeholders. The amendment in the nature of a substitute makes technical changes to clarify the length of the public comment period.
Any questions for Mr. Hoffman? Dr. McDermott, do you have one? Yeah, gentleman's recognized.
Mr. Chairman, I think it's a little bit, well, I don't know quite why you say it. This bill was dropped in on the 29th of May. We were not in session. So I don't know what you think was going to happen between last Friday and the weekend, and then we'd have the bill without any hearings. The reason I raise the question is that I would like to understand how this rating system is going to be adjusted by, what's your understanding of the language in it? Because I had never a chance to ask anybody from CMS or anybody else what this is all about. So I'd like to know from you, as the chair or the person in charge of the committee, what is this ranking? How's this ranking system going to be changed? What are they going to do? They're going to have hearings, or are they just going to sit and do it themselves? Or how are they going to do it?
The legislation simply asks CMS to conduct a review of the risk adjustment model and asks them to take into account when they do this review several things in the course of a holistic review. And it just singles out some components, two of which happen to be multiple years of data and multiple chronic conditions. So it doesn't ask that CMS take any action. It asks that they conduct a review of the rating system process, the risk adjustment process. Subsequently, if they find that in their analysis changes need to be made, the legislation asks that the Secretary then make those changes.
Usually bills are written in Congress to solve some problem that some member has figured out. Could you tell me what the problem is why we're asking for this? Why is it not already working? I mean, we've had Medicare Advantage for quite some period of time. So what's the problem that this bill is supposed to be dealing with?
There have been concerns raised about the accuracy with which the risk adjustment model is currently capturing. And so, again, the legislation is asking CMS to conduct a review based on the concerns that have been raised about the accuracy.
So the numbers are numbers. I mean, we know how much things have cost and so forth and how many patients. What is the concern? Is it that they then don't pay as much for certain numbers, or?
There are concerns that CMS made this year in their rate notice will change the accuracy of the risk adjustment system. So this is a response to what we've seen in the recent notices, asking CMS to conduct a further review based on what we've seen.
Who noticed that problem? I mean, is that the industry that came in, or is it a member?
Members of Congress have sent letters to CMS raising this particular point.
Would the gentleman yield?
Yes, yes.
Very briefly, and I'm one of those. Getting risk adjustment data right is important. One, you want to make sure plans are covering the more complex cases and more expensive ones, A. B, you want to make sure plans aren't disincentivized to take on complex cases with a lot of chronic care and expenses to them. We want to make sure, because it is complex, that CMS is looking at all the data. I looked at sort of their proposed request this year. It seems to me that expanding the amount of data actually is going to make it more accurate. And that's basically the heart of this whole bill.
And if you incentivize them to upcode their patients, then they will get more money. Is that the?
No. This is the whole focus on, are we ensuring we're paying for those complex patients, and are we incentivizing plans to cover those complex patients?
The gentleman will further yield. Sure. It's just, we're striving for accuracy. It's just that simple.
My problem with that is that for those people who want to get rid of Medicare, the way you do it is get rid of the sick patients, get them somehow marginalized out into the fee-for-service program, and get everybody else in managed care.
Okay, let's get into that if you'd like to, outside of the question period.
Mr. Chairman.
Yes.
And we're actually on the same side on this area.
But that's not really, we're not at that point right now. So if you want to strike the last word and have that conversation, let's do that, but let's get past the questioning of the staff director.
Mr. Chairman, could I just react briefly to my friend from Washington State's concern about where it comes from? I mean, there are...
It came from you.
There are a couple of Medicare Advantage...
Gentlemen, yeah.
There are a couple of Medicare Advantage programs in our community that are concerned that just precisely what you're saying, that they are not disadvantaged for being able to undertake complex challenges in terms of managing people, dual eligible people who have real problems. They want to recognize that this weighting factor reflects what they're actually doing. And I'm happy to give you a name of a couple of companies in Oregon that have raised this that you could talk to. I'm convinced that this is helping avoid what you just talked about in terms of putting people, casting them adrift, and trying to have the people who would benefit most from a comprehensive managed program being shut out.
I would appreciate seeing the data. It's not that I doubt that it's a problem. It's that we didn't have a hearing, so I've not seen it aired and seen it laid out and understand it, because I understand the philosophy that I already said about getting rid of certain patients and wanting the ones who are less sick. So I want to understand. I mean, we remember the days when managed care had the enrollment on the second floor in order to find out whether people could climb up the stairs to get up there to enroll in the program. I mean, or had dances to see if anybody could move around. You learned a lot from what went on in the past, and I'm looking for whether that's happening again or exactly what's here. So that's my concern. It's not the question of paying people for what they do.
Will the gentleman yield?
Yes.
Mr. Blumenauer controls the time.
I'll yield to my friend, or I'll yield.
Well, I'm just, Mr. McDermott is the ranking member on the Health Subcommittee, and am I correct in understanding that this bill was filed while we were in recess last week?
We were in pro forma session. I can
in
answer
pro
the
forma session last week, and you didn't have any notice of it as ranking member before that time. It's just a little difficult to move in a strong bipartisan fashion if our ranking member and the staff don't know that a bill normally taking months before it's considered in subcommittee is going to arise this way. And I've had some similar kind of challenges.
Could I briefly reclaim my time?
Gentlemen, let me ask the gentleman to yield back the balance of his time. Okay. Let's get into striking the last word.
Well,
I think that we're beyond the questions of the staff director right now.
Yeah, but there's an answer. I mean, this is not something that was conjured up.
This has been in the works for a long, long time.
This is something that has been in the hopper. There was some adjustment that was made in terms of what the committee deemed necessary in some instances to harmonize and pay for. But this is a legislative concept, has been legislation that's been out there for months. I believe, yes. Yes.
It was introduced in bill form?
If the gentleman will yield, this is the combination of three bills that have been out there for months.
Maybe that's why I'm having trouble figuring out which one of the pieces you're moving here.
This is black.
A little like the shell game.
Yeah, this is the Black and Blumenauer bill. I think we're done with the questions. There are no further questions of the staff director. Are there any amendments? There are no amendments. Does anybody move to strike the last word? Mr. Blumenauer, do you want to shed light on this? No?
I'm just saying this is.
The gentleman's recognized.
Thank you. We had this legislation last Congress, and we've had hearings. We've discussed it. It's a real. I'm convinced it's a real issue, and I'm happy to share some real people at home who are concerned with it. But I think this is part of what happened in terms of taking things that we've had on the back burner, in the hopper, that are fully, where members of the committee had access to it prior. I don't know if it's introduced in this Congress. It certainly was introduced in the prior Congress. I don't know exactly when it dropped, but we've been talking about it and looking forward to having a moment where we could launch this.
If the gentleman will yield, the committee is working on improvements to Medicare Advantage with this package of bills. So the committee looked to, among the membership, among the bipartisan bills that have been out there on improvements to Medicare Advantage, made sure that we had bills that were scored and ready to go. We found them, and that's what we're marking up right now. I yield back to the gentleman. Gentleman, yield back the balance of his time. Anybody else seek to strike the last? Oh, Mr. Davis is recognized.
Thank you, Mr. Chairman, and I move to strike the last word.
Gentleman's recognized.
Mr. Chairman, I want to commend my colleagues, Representative Black and Blumenauer, for working on this very important issue. I'm very supportive of H.R. 2579, Securing Care for Seniors Act of 2015. It would improve the risk adjustment in the Medicare Advantage program. One of the reasons that this legislation is so important to me, I don't think there are any communities in the country that have more kidney disease than some of those that I represent. And CMS has been making changes to the risk adjustment program that just don't seem to be grounded in sound healthcare policy or clinical data, as many of us think is necessary. CMS is removing codes for early treatment of chronic kidney disease and reducing payments for later stage treatments under Medicare Advantage. As we know, many health disparities are prevalent in minority populations where there are higher comorbidities. By removing these codes, it disallows treatment of early kidney disease and stop progression. As a result, this will cost more money and therefore defeat the purpose and intent to save funding and improve access to quality care. H.R. 2579 does not stop CMS from reducing the codes, but encourages the agency to make some changes to their risk adjustment model. Getting risk adjustment right is critical to ensure that plans who enroll the sickest patients are reimbursed accurately. And this bill will take important steps forward to protect their access to high-quality care. Unfortunately, what the current payment CMS has decided to move forward with has put plans, providers, and our sickest seniors at risk next year, and we should not allow that to happen. And so, Mr. Chairman, based upon even the discussion that we've just had, I'd like to work with you and my colleagues to address this issue and seek a one-year moratorium of the risk adjustment formula so that CMS can accurately fix this problem and so that we can ensure that the sickest Medicare patients get the care they deserve. Again, I commend the sponsors, Ms. Black and Mr. Blumenauer, and look forward to working with them, with you, Mr. Chairman, the ranking member, the chairman of the Health Committee and ranking member, and others, to work on this issue in such a way that we can ensure the sickest Medicare patients get the care, services, and treatment they need and deserve. I thank you, Mr. Chairman, and yield back the balance.
Thank you. I thank the gentleman for his comments and look forward to working with the gentleman on the issue. Ms. Black, do you wish to strike the last word?
Yes, Mr. Chairman.
Gentlelady
I
is
do.
recognized.
Thank you, Mr. Chairman. And just to bring some context to this, Mr. Blumenauer has already been said, he and I have been working on this for quite some time, and where we really see the disparity here is in the dual eligibles, because they are the low income and many times the sickest population. And really, if we can incentivize the care to happen early for them in the early stages, and has already been said by my colleague in Illinois, especially for chronic diseases like kidney disease, we really not only save costs at the end of the day, but it is a quality issue as well. Our outcomes will be much better. And what we have seen is that, and the reason why we're asking for the evaluation is it seems to be that group is really the one that is the most affected. Those who need the care the most and those who are at the low income and the dual eligibles. What happened in March was, as already been said by Mr. Davis, is there was a change of CMS in the what they call the CKD code, which is the chronic kidney disease code. And because of the removal there, we sort of decided that this needed to be looked at right away and more carefully. There was a letter that was sent to CMS by the committee. We had it through the chairman sent to them to question about the way in which they were setting these codes up and to give us some idea about what they were using in that evaluation, and also to encourage that they would include the stakeholders and others from the industry rather than just making those decisions at CMS. So that is really the impetus of all of this, is to get them to do some evaluation, come back and show us what they're doing, and help make sure that what we're doing at the end of the day is really giving quality care at the best cost that we can get. Not just looking at cost, but looking at quality at the end of the day being the number one reason why these codes are set this way. And that's the whole purpose of this, and I yield back.
General yields back the balance for time. Does anyone else seek to strike the last word? If not, the question is on adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2579 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2579 as amended. All those in favor signify by saying aye. Aye. Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 2579 is ordered favorably reported as amended. Without objection, I ask that the staff be authorized to make technical and conforming changes to the bill, and that members may have 2 additional days to file with the committee clerk supplemental, additional dissenting, or minority views. Home stretch. All right, the next order of business is H.R. 2581, the Preservation of Access to Seniors and Medicare Advantage Act of 2015. Mr. Brady, you are now recognized for an opening statement on this bill.
Thank you, Mr. Chairman. This legislation is a combination of hard work of several members, not only on the committee, but others as well. It includes 3 provisions. First would make changes to the open enrollment period for when seniors are able to select a Medicare Advantage plan. This was legislation introduced last week by Mr. Rothfuss, Mr. Schrader, and Mrs. Brooks of Indiana. Under the current rules, every year, seniors only have less than 3 months, from October 15th to December 7th, to review and select a Medicare Advantage plan. That gives seniors 60 days to compare their choices, weigh the decision to switch a plan if they choose, and select a plan. And if a senior discovers that, after this 60-day period, the plan he or she selected isn't actually the one they want, or discover the plan's network no longer includes a doctor or a provider they want and like, well, then they're just out of luck. Seniors used to have an additional 3 months to make this decision, but the Affordable Care Act changed that. True, right now, seniors who decide they want to switch plans after the enrollment period have the opportunity to disenroll, but their only option, if they choose to make this decision, is to enroll in the Medicare fee-for-service. They don't have the opportunity to opt into another Medicare Advantage plan, even if it's that is their preference. So this legislation makes a simple change, essentially establishes a secondary Medicare Advantage open enrollment period, allowing seniors to change plans from January 1st to March 1st. Seniors would still be able to leave their Medicare Advantage plan and opt into fee-for-service if they choose, but under this proposal, this would not be their only option anymore. They'd be able to find another Medicare Advantage plan that fits their needs. Legislation includes a second provision that would create a demonstration program for whereby Medicare Advantage plans would have the ability to offer plans with varying benefit designs that could lower cost sharing for seniors that rely on high-value services. This provision reflects bipartisan legislation that Mrs. Black and Mr. Blumenauer have worked extensively on. I want to thank them for their hard work. I know they'll have more to share on this proposal. I look forward to hearing from them. Finally, the legislation includes a policy to modify Medicare payment rules to ensure more accurate payment for infused drugs covered under Medicare Part D that are administered with certain types of medical equipment. It corrects an oversight that was contained in legislation passed in 2003 that converted the way in which Medicare pays for other Part B drugs. While most Part B drugs are reimbursed at 106% of their average sales price, these DME-infused drugs are reimbursed at 95% of their average wholesale price. The Department of Health and Human Services Office of Inspector General has pointed out repeatedly that this oversight has resulted in significant overpayments for a certain number of these DMA-infused drugs. At the same time, the old average wholesale price payment system has also underpaid for some of these infused drugs. It is past time that Congress correct this problem. So this legislation would simply move those DME-infused drugs that are covered under the Medicare Part B program into the average sales price payment system along with other drugs. Doing so would more than offset the cost of the other 2 provisions included in the legislative package. Closing, I'm proud of this package. It represents the hard work of a number of our key members, is fully paid for, and will make Medicare Advantage a stronger program in the long run. And before I yield back Mr. Chairman, I would like to ask unanimous consent to submit a statement by Congressman Rothfuss and Congressman Schrader for the full committee.
Without objection. Gentleman yields back balance of his time.
Yields back.
Gentleman yields back. Mr. Levin is recognized for an opening statement.
Thank you. Just so it's clear, this combines several different pieces of legislation. So let me now yield to Mr. Blumenauer, who has been working on one of the two pieces. Mr. Blumenauer.
Gentleman is recognized.
Thank you, Mr. Levin. And again, it's been a pleasure to work with Ms. Black. The value-based insurance design program is to try and coax more value, be able to make sure that we're doing being able to demonstrate how we can, for example, deal with adjustment of co-payments to either incent people to use appropriate treatments. We've had in Oregon a demonstration process ongoing, and it's had very promising results. By being able to adjust these incentives for things that will make a difference in terms of prevention and treatment, they've managed to reduce tobacco use, increase participation in weight management programs, reduce obesity rates by eliminating cost sharing on some very specific items. I think this is very promising to be able to get more value again out of the Medicare Advantage programs. The experience in my state indicates that this is worthy of exploration, and I'd be happy to yield the balance of my time to Ms. Black.
Ms. Black's recognized.
Thank you, Mr. Chairman, and I again want to thank Mr. Blumenauer for working with me on this bill. I'm really excited about this bill. This is one of those areas, again, from my nursing career, that if we can get people to use those highly valued clinical services, that we know that if they use those, we would lower the cost of care, but more importantly, create quality in their health care outcomes. That's exactly what this bill does. And so by giving them an opportunity to either reduce or lower those financial barriers so that they will use those services, this is really going to encourage them to take care of their health. So it aligns the patient's out-of-pocket costs with their co-payments for those valued services. And people will ask, well, where did this come from? Well, Dr. Mark Fendrick, who is out of the University of Michigan, actually has a center there called the VBID Center, where he has done some pilot programs there and shown some really good outcomes with the research that they have created there. I want to give you an example of how this might work. So if you have a patient that's diabetic, and we know that if they take their medication, if they go to the doctors routinely for their checkups, if they test their blood sugar, that their outcomes are going to be much better than someone who is not getting those services and taking care of themselves. So those would be what we would call the highly valued services. And in that, we would be able to either reduce their co-pays or even in some cases remove those financial barriers, because the less cost, the more likely it is that they're going to use that service. And if you are able to keep them healthy, those complications that cost lots of dollars, like amputations and kidney transplants, are really going to save money at the end of the day. But more importantly, once again, we know that this is going to have a better health outcome for those individuals. And so in this program, it is a pilot program that will be done in Medicare Advantage so that we can actually get those numbers and see that it does work. And I am really delighted to partner again with Mr. Blumenauer, and I'm also excited that in the Energy and Commerce Committee, Ms. McMorris-Rogers will have the companion to this bill. So thank you, Mr. Chairman, and I yield back the remainder of my time.
Gentleman yields back the balance of her time. The committee will now proceed to consideration of H.R. 2581. I offer an amendment in the nature of a substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the measure will be considered as read and open for amendment at any point and considered base text for the purpose of the amendment. I will now turn to Matt Hoffman, Staff Director of the Health Subcommittee, to provide a brief description of the bill, and I ask members to hold off on their questions until after his presentation. Mr. Hoffman.
Chairman Ryan, Ranking Member Levin. H.R. 2581 contains 3 policies. Section 1 establishes a demonstration program to test value-based insurance design in the Medicare Advantage program. Participants would be allowed to offer plans with a varying benefit structure that would lower cost sharing for high-value services. CMS would collect data and report on the effectiveness of this demonstration program on the increase or decrease of healthcare utilization. Section 2 would allow Medicare Advantage beneficiaries a second modified enrollment period between January 1 to March 1 of each year in the event the beneficiary chooses to switch to another Medicare Advantage plan. Under current law, during this period, the beneficiaries currently enrolled in a Medicare Advantage plan are only allowed to disenroll from their plan and enroll in a fee-for-service. Section 3 would adjust the payment for certain drugs covered under the Medicare Part B program. These drugs, specifically DME-infused drugs, would be reimbursed at their average sales price plus 6%, as opposed to the current payment methodology that reimburses them at 95% of their average wholesale prices that were in effect on October 1, 2003. This policy has been recommended by the Department of Health and Human Services Inspector General to address instances of Medicare overpayment in this category. The amendment, in the nature of a substitute, makes several technical corrections to the above sections, most notably to clarify that Section 2, regarding the new open enrollment period, applies to only those individuals who are currently enrolled in Medicare Advantage plans and not those beneficiaries enrolled in fee-for-service. The amendment, in the nature of a substitute, also includes a sense of Congress with respect to CMS interpretation of the benchmark cap as it applies to the Medicare Advantage bonus payments for high-performing plans.
Any questions for Mr. Hoffman? Mr. Blumenauer.
Yeah, I would, Mr. Hoffman, just explore briefly the sense of Congress. Can you elaborate on exactly what the sense of Congress would require in this case in terms of dealing with the cap?
It doesn't require anything. It is a sense of Congress that expresses concern with CMS's interpretation about how the benchmark cap is being applied and what that means to the quality incentive bonus payments. And then the second portion of the sense of Congress asks that CMS take another look at how that interpretation is being applied.
Mr. Chairman, my understanding, I mean, I am very sympathetic to dealing with the cap. This is a problem for states like mine, which are very high quality, but where we're dealing with the cap in terms of low cost, it's an issue. And I would like us to be able to address the adjustment of the cap. But my understanding is that CMS doesn't think that they have this authority. So I would think that we would be better off, instead of giving a sense of Congress, for CMS to do something which CMS, at least to my understanding, says they can't do. It would be better for us to either give them the authority to do something or that we take action to do it.
Would the gentleman yield?
I'd be happy to yield.
Well, and I think you're right on target in the sense that just as the previous bill hopes to create incentives to take care of the most very frail, our bipartisan concern on benchmark caps is that we're not incentivizing these plans, high performing, to keep improving for our seniors. And so the sense of Congress including this really is the signal to CMS that members of Congress are serious about looking at how this system works and serious about trying to develop a solution that helps create this incentives for higher quality. So we're going to have to work together, both parties, both members, on this issue.
And I appreciate your clarification, Mr. Brady. I look forward to working with you on it. I think it's important. I'm just concerned that we not direct our fire at CMS to ask them to do something that they say they can't do, and that we need to be working to make sure that they either have explicit authorization to adjust the cap or that we do something as a committee to fix it, because I, for one, would like to see some changes. Thank you.
Any further questions? Dr. McDermott.
One thing I wanted to ask, do I understand correctly that the open enrollment period is only open to those who have a Medicare Advantage program? If they opted for it in October and by January 1st they're dissatisfied with it, they can jump to another Medicare Advantage program, whereas somebody who took fee-for-service in October cannot go to a Medicare Advantage program in January. Is that correct?
That's correct, sir.
I guess you're not the one I'll ask down the way as to why you exclude all the people in fee-for-service, so I won't ask you. It's a waste of time.
All right, any further questions for Mr. Hoffman? No further questions. Any amendments?
Mr. Chairman?
Any?
Move to strike the last word.
Gentleman's recognized.
I have 25 amendments at the desk. Just kidding.
No, you don't.
We've been here for 5.5 hours. What the heck, right? Mr. Chairman, as Chairman Brady has already said, and I support this common sense piece of legislation, part of H.R. 2581 has a provision to change the payment for Medicare Part B DME infusion drugs. And as the Republican lead sponsor of the Home Infusion Site of Care Act, I support proper payment for Part B DME infusion drugs. Since its original introduction in the 109th Congress, the Medicare Home Infusion Site of Care Act has contained a provision that would alter this how Part B DME infusion drugs are reimbursed. And the bill ensures that infusion providers are paid appropriately for the services they provide at home. While it's clear we need to fix how Medicare Part B DME infusion drugs are paid for, I want to work with both you, Chairman Ryan, and Chairman Brady to ensure as we approach this issue in a more holistic manner that we ensure home infusion is adequately covered in Medicare, including in the home setting, so that all of our seniors have the access to the best possible care, even at home.
I appreciate the gentleman's comments. I know he's long been interested in this issue, and I look forward to working with him on it.
Thank you. Are you back?
Mr. Paulson, do you move to strike last word?
I do, Mr. Chairman.
Gentleman's recognized.
Well, I just wanted to follow up on what Mr. Tiberi just mentioned. I had the same comment, actually. These are important Medicare reforms, and I've spoken to some others that are also involved in the home infusion industry and want to make sure that anything that we have in this legislation is not going to impede the ability for those additional savings. I also look forward to working with you and Chairman Brady on that down the road. So, you'll bet.
Absolutely. Thank you. Thank you. Ms. Black, did you want to move to strike last word? You're good. Okay, I had you on the list. Anybody else? Dr. McDermott.
Mr. Chairman, I simply want to say I would like somebody that, when I'm through, to explain to me why you exclude fee-for-service people from moving to a Medicare Advantage program in this new open enrollment period. Well, it sounds like an in-house game for the churning inside the Medicare Advantage people. And what that's about, I have no idea. But I have a further comment about this. Everybody out there who's watching this and watching us change Medicare here with 5 pieces of legislation, or 6 actually, should realize 3 of them were put in a week ago and 3 of them were put in 3 days ago. And this is a runaway freight train here running through the committee, and I understand that a lot of this has been worked on in various places, but I've been doing this a long time, and every once in a while after a bill passes, something comes out and people say, well, how did that get in there? Well, it got in there because nobody knew it was in there except the people that wrote it. And you cannot go at 100 miles an hour like this and know what the impact, or think about what the impact. Some of these technical corrections are because they were done in the same way. Because if you had looked at them, you'd have said, well, wait a minute, how's this going to work? Because what you got to think about is you got a lot of people out there between the ages of 65 and 100 who are made to choose about their health care plans, and some are more capable than others, some are more willing than others, and in that kind of a situation, you have to think about what are all the implications of what you're changing. And this may all work out fine, but I don't think anybody knows at this point. Especially the question of risk adjustment. Risk adjustment has been talked about since I came to Congress in 1988. And people have been talking about how you figure out how to risk adjust one patient. It's a very difficult job. It's hard to look at somebody at any one moment and sell them an insurance policy knowing what's going to happen to them in the next 6 or 12 or 18 months. So how do you know when you're selling them the policy you're charging enough? If you're on Medicare Advantage, how do I know I'm charging you enough to make sure that it will cover what happens down the road, or am I going to lose money? That's the kind of issues that we're struggling with here, and we're really doing it very quickly. And I from my point of view, I think a few more hearings might have been useful. But
will the gentleman yield?
Over the dip, yes. Sure.
So let me pick it one piece at a time. The bill before us is new in the sense that they've not been combined before, and we have a pay for these bills. But these have been bills that have been introduced for quite some time, that have been well vetted for a long time, that are addressing problems with Medicare to make Medicare work better. So these aren't new issues or new bills for that matter. It's just new that the three are combined for the sake of efficiency and so that they're paid for. That's point number one. Point number two, risk adjustment. Data is getting better and better by the day. That means we, meaning this committee or CMS or the private sector for that matter, is getting much better at collecting data so that we can be more accurate in our measurement of things like insurance. The private sector has done a much better job at actually getting accurate risk adjustments, and we want to make sure that Medicare is tracking with that so that we are accurate, so that hardworking taxpayers are paying for a Medicare program that is being precise and accurate to make sure that plans are getting reimbursed for providing the care for people who have serious needs. We do not want to see a system where we're disincentivizing providers from actually taking care of the sickest among us. And so that's why we want to see more improvement on data collection and risk adjustment, because we already know from evidence that's out there in the private sector and other parts of government that we can do a better job than what's been done. That's why Mr. Blumenauer's had this bill for a long time. Mrs. Black has been doing this since the last Congress. So these aren't new issues that just sprung up. We're putting bills in a package together so we can then bring them to the floor so that they're paid for, and that's what we're moving because we're trying to improve this program, because we should be doing this. I mean, Medicare Advantage, fee-for-service, all need constant reform, need constant updating, need constant care so that we're getting the maximum benefit out of these programs. And that's what we're trying to attempt with this markup. Mr. Brady, you move to straight last word?
I do.
Gentleman's recognized.
Mr. Chairman, I'll be very brief. These bills oftentimes have been worked on for months and years, as you said, Mr. Chairman. We work very carefully with stakeholders, patient groups, Democratic staff, Republican staff, to find that common ground, the best solution. So oftentimes, the bills that are filed most recently are the most up-to-date. They reflect the most common ground. They're the best solution. That's one we bring to these markups. Secondly, Mr. McDermott's question, the whole concept of this bill is that there have been significant cuts to Medicare Advantage plans. Seniors can sometimes find almost immediately, if they go to the hospital or doctor, the ones they've been seeing are no longer available in this new network. So the question is, what options do they have? This bill ensures they can go to Medicare fee-for-service, or if they prefer, Medicare Advantage plans can choose one that fits their health care needs. I think we can agree we want seniors to have those choices and plans that fit them. That's the heart of this whole approach. Medicare fee-for-service, of course, doesn't have networks, doesn't need networks. This is just common sense access for seniors. I yield back.
Chairman yields back to other members. Move to strike the last word. Mr. Thompson, recognized.
Move to strike the last word.
Gentleman's recognized.
In an attempt to move quickly through the hearing, I made very brief comments on the bill that Mr. Brady and I had up today. I'd like to ask unanimous consent to have my full statement put in the
Without
record.
objection.
Thank you.
Any gentleman yields back. Any other members seek to strike the last word? If none, the question is on adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I now recognize Mr. Johnson for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 2581 as amended to the House of Representatives.
The question is on favorably reporting H.R. 2581 as amended. All those in favor signify by saying aye.
Aye.
Those opposed signify by saying no. In the opinion of the chair, the ayes have it, and the motion is agreed to. H.R. 2581 is ordered favorably reported as amended. Without objection, I ask staff be authorized to make technical and conforming changes to the bill, and that members have 2 additional days with which to file the committee clerk supplemental, additional, dissenting, or minority views. There being no further business before the committee stands adjourned.